you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick we shall overcome and walk right into a new start.
Welcome to the brand new world. We're the children of a Mother Earth. Reach out your hands, let us heal our earth together. Welcome to the brand new world. We're the children of a Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
They can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick we shall overcome and walk right into a new start.
Welcome to the brand new world. We're the children of a Mother Earth. Reach out your hands, let us heal our earth together. Welcome to the brand new world. We're the children of a Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
They can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick we shall overcome and walk right into a new start.
Welcome to the brand new world. We're the children of a Mother Earth. Reach out your hands, let us heal our earth together. Welcome to the brand new world. We're the children of a Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
They can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick we shall overcome and walk right into a new start.
Welcome to the brand new world. We're the children of a Mother Earth. Reach out your hands, let us heal our earth together. Welcome to the brand new world. We're the children of a Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
Stars, they can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick, we shall overcome and walk right into a new start.
Welcome to the brand new world. With the children of our Mother Earth, reach out your hands. Let us heal our earth together. Welcome to the brand new world. With the children of our Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
Stars, they can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick, we shall overcome and walk right into a new start.
Welcome to the brand new world. With the children of our Mother Earth, reach out your hands. Let us heal our earth together. Welcome to the brand new world. With the children of our Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
'Stars, they can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway.
Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick, we shall overcome and walk right into a new start.
Welcome to the brand new world. With the children of our Mother Earth, reach out your hands. Let us heal our earth together. Welcome to the brand new world. With the children of our Mother Earth.
Namaste. Please join us this Sunday on a free global online episode, Universal Health Coverage Day.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Global Namaste. Good morning, good afternoon, and good evening to all the viewers of Healing Our Earth. I, your host, Amrita, I welcome you to this episode of Universal Health Coverage. Universal Health Coverage is an important day where we address and mark upon the importance of affordable health solutions and to know about what best can be done where 4.6 billion population is without treatments and they cannot afford those treatments. To know more about what kind of issues people face around the globe and what all the health system is doing all over the world, we have our experts for today. But before that, let's start with Gayatri Mantra. Om Om Bhurvasvaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Dhiyo Yuna Prachodayam Om Bhurvasvaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Dhiyo Yuna Prachodayam Om Bhurvasvaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Dhiyo Yuna Prachodayam Shanti, Shanti, Shanti. Welcome. Universal Health Coverage Day, a day which is a little different because we're talking about something which is very important. It's mostly said it's very easy to fall sick, but it's very difficult to cure oneself, to get healed. And it takes huge amount of monetary and non-monetary efforts to get cured and healed. Let's hear from what our regular guest contributor from United Kingdom has to talk about, as she is my co-host of today's episode, and I would like to welcome her. Global Namaste and a very warm welcome, Kailashi. Kindly unmute yourself.
Sorry, Global Namaste, Amitaji. Thank, thank you so much again for inviting me to this very important episode. Health, as you know, health is everything. If you lose wealth, something is lost. But if you lose health, everything is lost, they say. So today, like I said, it's very, very important that we do talk about this because it's everybody's entitlement, access to good health care. It's everybody's entitlement. And I look forward to hearing to our experts today what they have to say about this on this very important topic. Having experienced myself the health system as well, and when you are, needing medical help, and when there is no facilities that are available, as you can imagine, those who can't afford it can be an extra additional stress on them, as well as coping with their symptoms as well, and not getting, if whether it's affordable or accessibility, whatever it may be, could be an added pressure, stress on them, as well as what they're going through medically. Now, very recent, I know we in the UK we have the NHS, but again, there are, because of the the stress that NHS is going through, understaffed, overworked, long hours, patients not always get the same treatment, that they deserve. And recently, as I said, one of my relatives who was taken ill, had to be on the corridors, basically. It took about over 12 to 16 hours to get access to any help. And in the end, they had to put the beds in the corridors, which is not appropriate. But as you can, this is one example. But then we've got the other spectrum where there are, like Amrita, you said, all these thousands of people who, are there without any healthcare because of affordability as well. So it's a real big global issue. And today it's an opportunity that we can discuss those and see how we can all come together to help address this need. So thank you, Amritaji, for giving me this
Thank you.
opportunity.
Thank you very much. It's time to welcome our first guest of today, Heather from Israel. Global Namaste, Heather, and a very warm welcome.
Global Namaste. Thank you for having me. Always good to see you.
Thank you. Heather, we have been discussing about addressing affordable health solutions, and you are very much into providing people affordable health solutions through various kind of therapies. So what is your talk about? And I think you are going to, excuse me, basically focus on creativity and a personal care as a building platform for individuals that might reduce the health burdens, right? And I think this kind of an approach where you build your own resilience is really beautiful. So over to you. Thank you.
Thank you for the introduction. So, I'll certainly bring in elements of the creativity with regard to supporting individual resilience. But today, what I wanted to play with is the idea of paying it forward and how it can be relevant in public health spheres for reducing some of the burden on the larger systems. But before we jump into that, I always like to begin with a simple embodiment practice just to invite everyone to really land in their bodies so that we're meeting each other from a parasympathetic state so that we can really create receptivity for all the information that's about to come. So I welcome you, first of all, to just drop into your breath. Just follow the natural rhythm of your breath cycle as it is right now in this moment on Sunday afternoon. It's afternoon here in Israel, but evening in other parts of the world and mornings elsewhere. So just land in the rhythm of your breath as it is right now and meet it exactly where you are with no other intention than just being and witnessing it. And having connected with that natural breath cycle, I invite you to add a hum to that breath cycle. Finding a natural rhythm to introduce this resonance into your body. Find a rhythm, find a tone that works with you. The idea being that we're creating a self-resonant structure in the body with this breathing. And simultaneously, we're activating the vagus nerve and inviting a parasympathetic response just through this humming motion in the body. So this is a really simple exercise that Peter Levine uses in somatic experiencing, where you're using resonance and sound as a self-healing mechanism. So I invite you to just use that throughout your day as part of this process of building resilience. And one other thing I'll invite you to do, warm your hands. It's a little bit chilly here, so warm your hands. And just invite your fingertips to come into the center of your sternum. In the kind of etheric, eternal medical fields, this is a really central location because it's the meeting point of the vertical axis of energy and the horizontal axis of energy. So just bring some attention to that center of the sternum, right in close proximity to the thymus. And just come into that space and bring that resonant sound of the humming into that space as a way of activating this connection to source energy, because we're right at the crux of this meeting of horizontal and vertical spaces. And let it find its own natural end. Just remembering this is an anchor you always have access to. This is one tool to have in your toolbox that you can offer yourself and for those you're in service to. as a way to really ground into the body, to use self-somatics, to use self-sounding as a way to build that resilience and build connection to this higher source that we all ultimately have access to, which is ultimately infinite in terms of its capacity to serve our overall and individual health. So from that place of tools, this is one small tool. I won't be focusing on this today, but an important note is the importance of democratizing education and providing tools that support body literacy so that each individual has ready access to understanding all the systems in the body. Especially for women, we've on previous calls we've talked about the hormonal system in women especially, but giving ready access to the masses to this information so that it's really democratized. It's not something that only a privileged few have access to. So body literacy is a really important element of these other two avenues that I'll address today with paying it forward. And I'll offer one example of an interesting organization that is really putting this into practice, which is Human Garage. I highly recommend looking into their resources. They have a lot of free content on YouTube, on Instagram, on their website. They have a very active community portal via an application that is free. And their focus, not exclusively, but their focus is really on myofascial release and providing tools and really basic, simple exercises for myofascial release. But they also talk about its correlation to other systems in the body. So just as a small example of democratizing education, building body literacy, I highly recommend an organization like Human Garage to just look into their work. But again, today my focus is going to be more on this concept of paying it forward. And I have two kind of models to offer as case studies and examples of what's possible, both of which are from the States. So from a direct sort of patient to patient community based model, I'll offer an example of Soul Kitchen. Soul Kitchen is an organization that was founded by John Bon Jovi and his wife Dorothy, his high school sweetheart Dorothy. They created, this is 2011, I believe they founded, with the basic concept of providing meals to all, creating an equitable environment where all individuals are served high quality meals, irregardless of whether or not they can pay for the meal. So the setup was very simple, where it was either a pay what you can model, or if they weren't, if the individual coming into the Soul Kitchen space was not able to pay for whatever reason, they were encouraged to volunteer for 30 minutes. So this really simple model was initially, highly criticized by its critics, but it's still very successful, and they have multiple locations now in the States with this simple model of pay what you can. And oftentimes those who are paying more than what's expected for the meal that they've enjoyed. And that then is going back into the pool, the cyclical pool that's supporting the community. And this is a really, it fundamentally is a community-led initiative. John Bon Jovi and Dorothy, created this space they only take credit for creating the space and restoring respect and dignity to all those who come in, which is a big difference from food banks, which can be a bit cold, and there isn't that sense of connection. What they're wanting to foster in that space is a sense of warmth, connection, and restoration of dignity. And what they found are the long-term effects of this pretty simple business model, and other celebrities have gone on to create similar ideas. But they've seen improved mental health, stronger social connections, better overall stability within the community setting, more community engagement, and an overall elevation and restoration of the power of community itself. From this idea of providing meals, but what they're really doing is providing dignity. So if we were to take a similar model and apply it to a healthcare perspective, where we're creating community hubs of medical care, and every client, every patient that comes in is, again, similar model where they're paying what they can, If they're not able to pay, then that they're volunteering time and energy into contributing back into that space. And the idea being that it creates the momentum that supports the community at large. I think that's a beautiful point of consideration for remodeling and re-envisioning healthcare as readily accessible to all. So Soul Kitchen is one example of positive influence on the ground, really in the trenches, on the ground, building community care models by supporting one another, in this case, within the realm of food, within the realm of nourishing. And on the realm of practitioners, how can we change the model for practitioners? There was mention of the burnout of the practitioners within the NHS model. This is a very real issue globally in terms of the challenges that healthcare professionals have. You have a system that fundamentally doesn't support them as much, which then in turn limits how they can show up and cultivate. Invite their patients to cultivate resiliency when they are so fatigued and burnt out. So an example of another pay it forward model that provides new opportunities for creating a different type of practitioner. There's a medical school in Arkansas in the United States, in a little town of Bentonville, Arkansas, that was recently opened, July of this year, that they welcomed their first medical school class. It was founded by Alice Walton, who is one of the richest women in the world. She's the heir to the Walmart fortune. And she has been in a process of creating this fairly innovative medical school for several years, and it's finally opened its doors. And one of the unique elements of it, beyond the fact that it's integrating arts and humanities into the medical training model for the new practitioners, is the fact that the emphasis is on whole person care and preventative medicine. Whole person care and preventative medicine, with the starting point being the practitioner themselves. So they're cultivating practices for the practitioner to have ready access to creating that very resilience that will then be able to trickle down to their patients as well. One thing that's unique, in addition to this preventative medicine approach and the whole person principles that are guiding every facet of this medical school, is that the first 5 years of medical school students coming through the doors of Walton Medical School, their tuition is paid for, courtesy of Alice Walton herself, with the expectation that those graduating from the program will return the favor, pay it forward by staying in the local community or surrounding areas, especially in Arkansas, because it's a very underserved and medical desert in terms of care. But the idea being that the medical students graduating from that school will be coming back and restoring, giving those skills back into the community. So we have two examples of opportunities for paying it forward and how it could potentially really benefit and change the face of healthcare as we know it. One, which is very community based, where you have a pay it forward model of nourishment in this case, whether it's food or healthcare. I think they're essentially one and the same. They're interchangeable, or the potential is there. And then on the practitioner model, creating new models of education for creating new practitioners with a broader sense and more comprehensive approach to how they're treating their patients, that are funded so they don't have the stress of debt coming out of medical school, so they can then give back into that cyclical nature over and over. So I think these are two interesting examples for consideration. And I thank you for listening. I'm happy to be here. Global Namaste.
Thank you very much, Heather. In fact, you shared that small aspect of what we discuss about the important key points in relation to providing the healthcare solutions. So there are two different aspects which I find in providing healthcare solutions. One is the aspect in terms of your knowledge education and how well you can keep yourself, and then providing and giving certain helps through different community services, as well as educating children regarding their wellness and well-being. I think is one of the very good ways to serve and give affordable solutions where everybody can be self-reliant for finding up things, decreasing the burdens on the health costs as well as the hospitals. So thank you very much. Before you sign out, it's a very important question that I wanted to ask, and we will be shortly moving to Dr. Damayanti in Sri Lanka. Um, what about the health burdens recently in Israel after the war, and what all changes
Mhm.
have happened?
Ooh.
Can you throw some light if you have any idea?
Oh, well, it's certainly not an area of expertise for me. I can just speak to and
That's
celebrate the massive volunteer efforts that have come together in the wake of the war. You have such a mobilization of healers from across the spectrum that mobilized and offered free treatments, free sessions for soldiers, for wives of soldiers, for Nova survivors, survivors of the festival where one of the massacres occurred. um so that was the biggest thing, is mobilization of the healers who at their private expense, for 2 years were offering free sessions, free tipulim, free treatments, for those
Mhm.
who are really on the front lines. So it was really a mobilization and a ground effort to support the upheaval and the chaos that we experienced. So it's really a shout out to, and I have many friends who were among those who were giving treatments, 20 massages every day to soldiers on the border. I mean, every day.
Oh,
Yeah.
hmm.
Yeah.
Affordable health solutions, definitely. And patriotism is remarkably shown through the country in this way, actually. So your contribution as a citizen it's not necessary. You have to monetize things or give and build up some momentums and
Yeah.
mementos. These momentum of giving people services free of cost, which is part of a requirement in any part of the country, and services like this and community work helps a lot. Thank you so much for
Yes.
being with
Thank
us.
thank
And
you.
best
My
wishes
pleasure.
for your son. Enjoy
Thank
your
you.
day. Thank you so
Thank you.
much. Thank you. It's time to move from Israel to Sri Lanka, where we have our Ayurveda expert, Dr. Damayanti Fernando. Global namaste and a very good evening to you, Dr. Damayanti. Dr. Damayanti, you have been working in, yes, you are already unmute. You have been working in the health sector in relation to Ayurveda, and you practice Ayurveda in Sri Lanka, right? Uh, in this way, what are your ideas and what do you see as an insight in the country? What kind of health issues do people suffer the most, and what kind of affordable treatments they can work on? Um, in terms of the conventional medicine system as well as the alternative medicine system that people adapt in the country. Over to you. Thank you.
Mm, Thank you. First of all, thank you very much for the invitation, Dr. Amrita. I hope I'm audible.
Yes, you're audible. Thank you.
Okay. So before I start my discussion, let me pray to Lord Dhanvantari because I'm Ayurvedic practitioner. So Dhanvantare Namaha, Gurave Namaha. I will start with a small prayer. रागातिरोगान् शततानुशब्दान् अशेषकाय प्रसितान् अशेषान् औत्सुक्यमोहारतितान् जगानान् योगोपवैद्याय नमो तस्मै. So this is my first time talking with all of you. So I don't know. I think we all are from different specialties. So let me tell you a tiny bit about Ayurveda and then tell you the condition in Sri Lanka. So in when we start learning Ayurveda, we study Charaka Samhita. In that, it is said that health is of utmost importance because as humans, we have four aims of life, that is Dharma, Artha, Kama, and Moksha. So, Dharma is about your duty, Artha is about your monetary efforts, and Kama is about your family, how you achieve your family, and the Moksha is about your spiritual health, what you achieve in this life. So, Ayurveda says that to achieve all this, you should be in good health. And as a Buddhist, Lord Buddha also say that your biggest wealth is not the money, but how much of health you have. So your biggest wealth is your health. So understanding that, when I look at my country, the condition in our country today is that um, the we have taken health for granted until we become sick. So we think health is our birthright, that we don't need to do anything to maintain health. But that is not true. So what has happened is, in our country, most of the people will run to healthcare professionals even if they sneeze. They don't try to think or understand consciously their body. They would simply run to healthcare system. And I think most of the people have given the responsibility of their health to the NHS or the National Health Service, rather than being responsible for our own health. So as the topic goes, the healthcare is unaffordably expensive even in our country. So if I talk about the healthcare system in our country, we have hospitals which have free service, but when it comes to free service, it is overcrowded. The necessary medicines are not available. Even the healthcare experts are not available at the given time for the patients. I'm not talking about the emergency care. Emergency care is very good, like for example, accidental injuries and all. It is treated very well, even in the government hospitals. So government hospitals in our country, it is free of charge. We have health insurance, but that health insurance is always private. And the interesting fact is, the mainstream of medicine is considered as the Western medicine, but Ayurveda comes as the second best medicine in Sri Lanka, even though we traditionally practice Ayurveda for centuries together. So only the mainstream medicine is covered by the private healthcare insurances. Until recently, even though we can give a prescription, our prescriptions cannot be claimed by the national and the corporate or private sector. But now we have achieved a lot, that Ayurvedic practitioners' prescription at the OPD level, if I prescribe some medicines, that can be claimed by government sector and the private sector working individuals. So that is quite an achievement, because that means Ayurveda is becoming more recognized day by day. But till now, the insurance policy does not cover Ayurvedic treatment if somebody goes to a hospital. So obviously, the treatment is expensive, because the medicines, herbs, the professionals, the nursing care, everything is costing a lot of money. But then, what I feel is, if we take responsibility for our health more than before, if we go towards or revisit our traditional knowledge, we could achieve a lot. For example, I think that is why Ayurveda has been very clear and very stern in giving due importance to dinacharya, that is daily how you should behave. And the Ritucharya. Ritucharya is seasonally how you should change your diet, the lifestyle, exercise pattern, everything, even the clothing. They say whether to go out or not. Everything is mentioned in Ayurvedic Dinacharya and Ritucharya, and I find it very scientific and logical even till date, even though it is 5,000 years back that it has been described. If I take, I don't go into detail of all that. In future, if anybody, all of you are interested, I can tell you point by point, and I'm sure there are other Ayurvedic practitioners here who can join in this discussion. And so if I take one example, we have a massage, which is, we call it in Sanskrit as Abhyangam. This massage is done with oil. So in Ayurvedic classical texts like Charaka Samhita, it is very clearly mentioned that if you do Shiroabhyangam, that is head massage with oil daily, you would never have a headache. And you would have good eyesight, good smell sense, good hearing, good taste sensation until the day you die. And in our text, we say our lifespan should be 100 years. So, like, it is very important when we talk about the geriatric care also. Nowadays, it has become a burden in many countries, the geriatric care. So if you are healthy as you grow old, I think it would not be a big health cost. So now I have been practicing this since young age. Most of the time, I would apply oil on my head. So then what has happened is I rarely get a headache. So I know that what has been said is true. And similarly, see that in our country as well as in all your countries, I'm sure, the lifestyle related diseases like dyslipidemia, heart disease, obesity is increasing, and the cancer. So I find that there is a tremendous change in the past 50 years. That is, we avoid biological detox. We call it as shodhana, purification in Ayurveda. And we, in the ancient times, in the traditional practice, once a year, we have been given certain herbs to detox our body. So this is quite important because that gives a chance for the liver and the whole digestive system to repair and reset. So this process has been missing. So that will lead to accumulation of biological toxins over a period of time in your body. Then what happens is your immunity will change because the immunity will recognize these biological toxins as a threat to your body, and it will start attacking your own tissues from the like the most weak point. So weakest point will be affected. So that is why we have autoimmune diseases mushrooming. So I think that if you practice Ritu Shodhana or the Shodhana of purification once a year, and it does not have to be very strong, it can be a mild Shodhana where you have to spend just one day in a year to detox your body. So if you do that, I think it will have a tremendous life-changing effect on your life. And coming back to the health burden, I think it is also necessary that we try to take responsibility for our own health, even though our healthcare is partly free of cost, and our tertiary education, that is university education for learning traditional medicine, is free of cost. Even then, it is people are not very aware about the traditional knowledge. So I think one part of our work is to improve that, excuse me, to create awareness about the traditional lifestyle and the diet. And we have this concept which is called as prakriti. In the prakriti, what we do is we we talk about your personality. Once we know your personality, we can identify what diseases you are prone to get in future. So in that way, if you know what you're supposed to get in future, you can do everything to prevent it. So instead of running to the hospital. So I think these are the things we can do to change our perspective of what we expecting from the healthcare institutions and do everything ourselves. So, and I believe that health is not merely the absence of a disease, it is the complete well being, physically, emotionally, mentally, socially, and spiritually. So, in that concept, I'm very happy to discuss and in future even about these practices if you need any more information, and also to restore this knowledge into at the community level and at the for the children. Basically, we in Sri Lanka, we are trying to do that, to introduce this knowledge to children, school children, so that they will know how to maintain their health. And so these are the things I would like to add. And thank you very much, Dr. Amrita, for giving this opportunity to speak, and to your kind invitation to share this knowledge with everybody. I'm very happy to be here. Thank you very much.
Thank you, Dr. Damayanti. Um, Yeah, I think the conventional medicine as well as the traditional medicines as well as the alternative systems of medicine can offer a lot of solutions for reducing the health burdens in different parts of the world because they provide a different approach, which is most of the time non-pharmacological approach. These approaches are more holistic. These approaches are interdisciplinary. These approaches are also very much personal, people-centric approaches. And that is why I believe these kind of traditional approaches, where when you mentioned about Ayurveda, that can help us in giving the guidances about the Ritucharya, the lifestyles. If you promote a healthy lifestyle or right eating habits, that may also reduce a lot of burdens. Like recently, the studies that have been taken place in terms of obesity, or we talk about diabetes, these kind of lifestyle disorders are basically the cause of the the irregular habits that we have, but they have an increased burden in society in terms of the complication that diabetic patients have. We also have, we'll be talking very soon from some of the people talking about organ donation, where there's a need of kidney transplantation due to diabetes, or there is a need of retinopathies, treatments for the diabetic patients. So all these things have been interrelated with the increased health burden. Before you sign off, we'd like to have a comment from Dr. Kailash. Dr. Kailash, you have a question?
Yes,
Please.
absolutely. Thank you so much, Dr. Damayanti ji. It was very interesting what you talked about, especially the Ayurveda, the whole body experience, body, mind, soul, everything. It's inclusive. And what I liked about your talk is about the education as well. It starts right from the beginning, like we need to educate our children as well about the eating habits, all about lifestyle habits, our thinking. So I would like to really encourage, and I take that forward from today's talk. It's about, changing those little habits, isn't it? Cutting down on sugars and stuff like that. So it's all about education and the lifestyle. So very, very interesting, very, what do you call it? It's uplifting, to be honest, today, your talk. So thank you so much. Thank
Thank
you.
you so much.
Yeah. So I think Dr. Kailash, you also staying in UK witnessed a lot of other things that traditional medicine can heal. Um, Before you sign off, Dr. Damayanti, can you talk about a little a comment of yours before we move to Subhashi for our further talk about what kind of common diseases or disorders do people in Sri Lanka suffer from, and what is the basic health burden that you feel people are suffering from in Sri Lanka? Thank you.
Yes, of course. Um, uh, it is all the common diseases, like as I told, lifestyle generated, like diabetes is a very common condition, which was not like that 10 to 15 years back. Also, the cancers, the number of different types of cancers are rising in children. The children related cancers are rising. So that is why I spoke about child health, and we are trying to educate the children as to make their own decision to choose healthier food rather than eating fast food, because Sri Lanka is becoming very much how do you say, the we are a developing economy, but still it is becoming very much westernized, and the traditional food habits are lost. So this has become a major cause of illness for the children. So that is why I spoke about that, because if we can save the children, if we can make them aware to develop better habits, then I think we can save the next generation at least from this lifestyle related conditions. And they are very ready to listen, and they are very open minded. When we speak to children, I go to schools and I try to speak to them, and they are very interested to learn yoga and to even the breathing practices. And when I tell them that what is included in the French fries, the burgers, and how the Ayurveda talks about viruddha contradictory food. When I explain to them, they take it to their heart and they practice it. And I see that they understand it better than sometimes the adults, you know. So that those
Yeah.
are the conditions that we have. That is why I spoke about the children, because I think they are our next hope.
Yeah.
And I try to encourage them to have Swarna Prashana and to have the all the what we have the Rasayana concept. I tell them that if they start taking ghee, they will have better memory, better skin complexion. Then they are very interested.
That's lovely. So please stay around and we'll have more chit chats with you. And it's time to move to our next guest, um, Subhash Sukharji. Global Namaste to you. A very good afternoon.
Very good afternoon to you.
So you had been listening to all the stalwarts who have their own perspective. They belong to different parts of the world. And so in today's health coverage episode, what do you like to highlight on the key issues that you see in the people and also with your age group? I would like to also address what kind of common issues do you feel that the geriatrics have, like the old age uh, senescence brings in terms of organs or in terms of eyes, in terms of issues that are very distinct, and what kind of affordable solutions do you think the country is providing? Over to you. Thank you.
Thank you very much for inviting me. Uh, my background is pharmaceutical sciences. I've got a education in pharmacy, but since quite a number of years, having worked in the pharmaceutical industry, and then moved on to educational part of working in a charity. Since last about I would say about 18 years or so, I've been very much involved into eye health. Now, just to give you an example how the whole story started and what I mean by eye health and what are the issues faced by both ways. I mean, not from the diagnostic point of view, from the treatment point of view, but from the patient's understanding and the following regimen which has been prescribed. And basically, when I came in from the industry to a charity, just looking after glaucoma, and there was the first meeting where I was asked to go and give a presentation to after the consultant had a talk about glaucoma, the diagnosis and treatment part of it. And my boss had told me, okay, you're a pharmacist, you know about eye drops and all that. Why don't you go and give a talk on eye drops? So, yes. So, yours truly, I looked at the whole pharmacy range of products which are available. So, put the names of the product and all the constituents and blah, blah, blah. In first two slides, I realized that the whole thing was not going very well because I had about 60 to nearly 70 people in the audience. And I'm quite perceptive to the the vibes from the audience. And you can see that a total blank faces, right? And I had Caucasians and few African Caribbean people in the audience. So I stopped in my track and I just asked, I says, come on, I think it's not going very well. Would you like to tell me exactly what I'm not doing right? Now, do you think anybody from the audience would tell a speaker what he was doing right or wrong, right? So I said, please help me. This is my first time I'm speaking with you, and I'd like to know something from you. So there was this lady in the front row, and she said, you know what? I haven't understood a word what you've said. And that was the beginning of understanding the patient's perspective. Now, the problem here is, as I'm talking about ophthalmology, eye care. This is the area which I've been working since last about now 18 years or so. The thing is, eyes. Now, we all in the audience here also, we all here do not look after our eyes unless a speck of dust gets inside or you have vision problems and all that. And then suddenly you want to go to an optician or for an eye checkup. So this is point number one. Now, the second point is that, okay, once you've been to an optician here in the UK, it's like this. You go to your optician first, and then you get, they go through the test and all. And if they find a problem, they are being sent to the hospital. Or in case if there is an ocular injury, you straight go down to the hospital, to A&E eye hospital. But I'm not. Those are the different aspects of it. The main problem here is that, say, for example, in long-term medication, especially in glaucoma or even in dry eyes and after cataract, the first line of treatment is always eye drops. And this is where I found the issues here. Now, when we're talking about eye care, eye health, the community part of it, taking responsibility for ourselves, great. It's a very good thing. But the main thing is education part of it here. Now, when I looked at, I'm talking about an experience in Moorfields Hospital where I sat down with the patient to find out exactly what was the situation going around. Now, there was a video which was being played, which they were showing how to put the eye drops in. And I was looking at the patient and I didn't find any reaction or anything. So I just asked, "Did you see that video?" I said, "Oh, what was that about?" Now, this was the starting point because you are in a hospital environment, you're waiting for your name to be announced. And even if there is an education thing which is going on, you hardly pay any attention to that. It has to be very, very personal, especially when you are on a long term eye drops medication. That's how my whole journey started, to create an education program for the patients. Now, why? Again, and I'm sure you have got experience here in the audience as well, here, and even in the panel as well. If you were given an eye drop to put in your eye, how would you do it? Can anybody show it to me? Just pretend. Dr. Sharma? Right. Okay. There you go. Dr. Sharma, yourself? You know what? I've been asking this question since last 18 years and not a single person knows exactly how to put the eye drop
I
in.
remember your talk when you gave on the first time, talking about the way to put the eye drop, and on the lower lid, the drop should rest. And that's the most important thing. And I taught everybody in the family, to be very honest.
Yep. But that's what it is. Now, why it is very so much important? Because if you got an eye drop, if you put it at the right time, this is education I'm talking about. Put the right at the right time in the correct way. Hmm? What it does, it gives you the maximum benefit of the medication which is being prescribed. Number one, it also cuts down the cost as well. Because I've seen people, flushing their eye with eye drops. Doesn't work like that. So you finish your eye drop within 10, 15 days. Another thing with eye drops is, especially this part of medication, I always give this example to patients when or a group I stand before and talk. So, for example, if you've got a headache, you take a paracetamol or right? And after half an hour or 2 hour or so, the headache is gone. So the perception is headache, paracetamol, headache gone. Eye drops. Here is something you have to deliberately put into your eye. You have no perception of what it does in your eye, right? And so, and this is a foreign substance. Sometimes it burns, it itches, it is difficult to put in the eye as well. And patients think, I don't see any difference, and they stop using it. And I've seen patients who have been regularly getting their prescription filled in and haven't used a single eye drop for 1 year, and their glaucoma has progressed like nobody else. Likewise, even after cataract, there are two drops which are given, antibiotic and anti-inflammatory. And I've seen patients not using it correctly, and after actually the healing should have been done within about 3 to 4 weeks, extends, and they blame the doctor. I was supposed to get my eyes correctly. I went to cataract and looked it. I've come across this. So education, what I say, education, education, education. It is very important to see that the end user understands why it has been prescribed, how your drug works, when to put in correctly, how to put in correctly. And that is the crux of the whole matter, education. Now, when I looked at the whole scenario here in the UK, I started looking at the different ethnic communities as well. Of course, I go in the hospital where, whenever I go to the hospital meetings, you wouldn't believe the audience. I would say 98% is Caucasians. I don't see African Caribbean people or even Asian people from Asian ethnic community attending this meeting. Hardly few, two or three will come. I realize African Caribbean people and Asian community people have got maximum problems with glaucoma, with their AMD, or even after cataract care. Why don't they come to the hospital? Nobody wants to go to the hospital for an education part of it. Seriously, I tell you. Because with ophthalmology, what happens? You go, your appointment is at, for example, 9 o'clock in the morning. You go there, and the whole process takes about 2.5 hours to go through all the examination and everything, right? And what the patient wants at that time, he wants to run out of the hospital. It is a fact. And that's where the problem lies. Because the consultant, having prescribed a product or a medication, has no clue whether the patient has been using it correctly or not. Number one, after 3, 6, or 8 months, when they come back for re-examination, oh, intraocular pressure is increased, the visual field has gone down. So what they do? Second prescription. I've seen 4 different prescription coming to that patient, and patient not using it and still getting problem. Where education, the information, the education are completely absent. I started this program in Moorfields Hospital. This is Know Your Drops program. Took me 3 years standing in the Moorfields Hospital to make them understand the value of education. You have a dedicated nurse, or now they've got ACLOS, what we call uh, eye care liaison officers. Brilliant people. You train them, and they have got enough time to talk to the patient as well. But what I find the most is, say, for example, a few months back, I was at Nisdan Temple, the Hindu temple. They invite me twice a year to give a talk there. 600 people. I had a friend consultant from Moorfields Hospital. He speaks in English. We did only cataract this time. Speaks in English. I interpret in Gujarati. Believe you me, it it works so well. That 1 hour of interaction directly with people from a consultant as well as from somebody who knows, say, for example, me speaking in the language, I speak 3, 4 languages. So it is another added advantage. And believe me, education works. My logo is always educate for better outcomes, whether it is patients or whether it is the provider. Education, both ways it works. I have been invited to, for example, clinical meetings in the mornings, breakfast meeting, meetings. There are about 40, 50 registrars, students, consultants, and all that. The same thing, I said CAP. How do you have to get the patient into understanding exactly what you are doing. And when you prescribe, at least spend 5 minutes with them. If you don't have the time, have a dedicated person who will be able to explain this to them. And I think, again, when I saw you trying to put the eye drops in your eyes, I've got these whole videos out there, about 7 or 8 videos of which has been filmed on me. And I have also printed out instructions as well, how to put the drops in, when to put the drops in. And anyone who is interested, let me know. I can send it to you by email, and just distribute free. And talk to the patients. Always, whenever you see anybody who has been having cataract or glaucoma, or eye drops, or even dry eyes, which is a very prevalent thing right now. I've been working with one of the consultants from Ireland, and she's absolutely brilliant. She has actually dedicated her research on the effects of cosmetics on the eyes. And it is, imagine, and since that day when I met Nina, I started looking, whenever I travel, I look at people's eyes. It's amazing, especially, people, I mean, not against ladies and all that, please spare me that. But people using mascara, false eyelashes, the amount of damage which does to the eyes, unbelievable. And I've been giving these talks at our ethnic community meetings as well, that during the festival season or go for weddings and all that, people, if you put huge makeup, no problem with the makeup. But you need to see that you clean your eyes correctly. And that is very, very important for you. Any questions?
So, global namaste to you, Subhash. You've, of
Namaste.
course, been here on Healing Our Earth before. Education, you are very right. If people can be educated, and you have mentioned one example that the guy got prescription for 1 whole year and never used it.
Yeah.
Now, effectively, it is his loss. Because if you want to ignore, the doctors don't just willy-nilly prescribe. Yes, carry
I'll
on.
differ here. I'll just differ here. Why that person did not use the drops for the whole year? The reason was, when I asked her very gently, you have to probe them. Really, I tell you. I said, have you seen the difference when you come back to the hospital? Your vision has deteriorated quite a lot. Do you know the reason why? She said, no. I said, the reason is because you were not using your eye drops correct. And you know what she said? I tried it first time. It was difficult to put. It was going all over my, the cheeks and all. It never. And when it fell in my eye, it burned and it stung because it was with a preservative, right? And she said, I didn't have a problem. My doctor has given me a problem of putting. Why should I put this? But when she came back to the hospital, again, this is. Let me give you another example. Just before I start, I was sitting in King's Hospital up there, OPD, glaucoma. And I heard these two African Caribbean ladies talking among themselves. I was not eavesdropping, okay? I was sitting at the back and I was listening. You listen to people, and these two ladies were talking among them. The first one said, when I come to this hospital, they give me all that, these eye drops and all that. And it burns and it stings and all sorts of things which happen. So the second said, so what do you do? Oh, I put it before I come to the hospital, 2 days before I come to the hospital. Wait a minute, this one. The second one said, I don't have that problem. But what happens is, come winter, I go down to Bermuda, and my doctor gives me 2 months a prescription. I take it from here. And sometimes my son gives me a phone call, Mama, don't come here. It's snowing here. It's very cold. So Mama stays there, and Mama has run out of the eye drops. Now, when she has run out of the eye drops, she can't get it there, number one. And if she wants to go and buy them, it's very, very expensive. So Mama doesn't use it. So when I went for the meeting with the consultants, we were just talking. I said, guys, you've got a problem out there. I said, what? So I relate this. I said, you need to, you don't question them. You have to ask them. But they said, this lady puts it too. So when you ask, are you putting your eye drops in? So she's not lying to you. She said, yes, but she's not actually using it. And this is how you have to actually explain it to patients and get the information out from them. And believe you me, patients are not stupid. They're very intelligent people, but they're scared. And you need to have that empathy to speak with them to find out exactly how to deal with their issues. And that's what it is. So whenever you see people avoiding medication, I've seen people avoiding even their blood pressure tablets because it's causing problems. And they just stop it. But unless you have to find out what is the problem, what is the side effect, okay, let's move to another product. Let me the one which is you'll get comfortable with it. So again, I said education part, whether it is to medical fraternity or to the patient, to the end user, I'm a very firm believer in it.
Anjali, your comment?
Any comment?
Thank you. Global Namaste, Neil Kumar ji. Global Namaste, Dr. Shivash. Very important message you've given to us of patient education. And
Yeah.
especially, I never knew that there was a way to put an eye drop. First time I'm hearing out from you. And most of the times when we put, it is kind of irritating the eyes or just coming out of the
Yeah.
eyes. And I
Yeah.
think that's the reason it takes a longer time if we have an irritation in the eye or any kind of problem with the dry eye, especially. It really irritates us because we're not putting it properly, and half the medicine is being wasted.
Yeah.
And I think it's a big economic burden on, like
It
places like
is.
NHS, which actually gives you free healthcare. And I think that's what we need to understand how to use it properly and educate the patient and the family members also. I think it's very
Yeah.
important that the family members should be informed of using it properly because the patient may not be able to use it because of some reason, because they are scared to use it or whatever.
You are very right. I have always asked when I speak with the consultant, I ask them, you're excellent at looking at the eyes. Have you ever looked at the patient's hands? You've got an
No.
elderly patient,
Yeah,
right?
she's trembling.
With arthritis, and you
Yeah.
prescribe a small little bottle,
No bottle, yeah.
how are they going to put it in the eye? Isn't it?
True.
Right. Now, here in UK, we have got lots of different aids which are available, which with a patient with a dexterity problem can actually use it. But you need somebody to explain and actually give it to them, isn't it?
Correct.
So
Yeah.
this is it's a very big issue, and I think I'm trying to make a dent, which I think I have made a dent. But because you see what happens when I receive an email from a nurse saying that a patient came to me and she was expecting you to come and meet you at another meeting. And she saw you 18 months ago in a meeting. And she was, for 16 years, she was trying to put the eye drops using a mirror, which was very wrong. And when I showed her this technique, for, and she has been using it, her actually progression of the visual field has been arrested, no second prescription, and she's absolutely happy with it. So you see, the education works, and this is when I hear these things. Believe you me, the satisfaction which I get is immense. Education, education, education.
Kailash, your comment?
Absolutely agree. Thank you so much, Supashi. Again, a very enlightening presentation. I come from an educational background, so again, everything's about education. We heard earlier from Dr. Daminti ji about educating children, raising awareness. Again, like you said, patients are people, real people. They're well educated. They may be well qualified doctor, accountant, whatever. But there is this element where concepts have to be broken down. This technical medical language sometimes, when you're not feeling your 100%, it doesn't always digest, it's not always very clear to it. So again, the special skills that medical staff, ought to obviously, you know, um,
You're very right. Yeah, I think empathy, I would put it just empathy, just
yeah.
looking at a person, not as a patient. And this is one thing which is very important, number one. Another, a few years back, I was invited to a church in Tooting area. This is the last example I'll give it to you. And it was a Sunday evening. When I went into the church, it was massive. There were 900 people of African Caribbean origin. And I said, this is going to be fun. And there are 10 huge screens around and technologically absolutely perfect. So they took my memory stick, put it inside, and the presentation came in. And the first thing I stood before the audience and said, how many are you from East Africa? This is the black population, okay? I think about 50, 60% hands went up. And the first thing I said, Jambo, which is a Swahili greeting. It just broke the ice completely. I speak Swahili, makes a massive difference. I was supposed to be for 1 hour, 2.5 hours on a Sunday evening. But that made a massive difference in making them understand for African Caribbean people you have to go and get your eyes checked to your optician first. Why don't they go? They think if they go there, they are going to sell them the glasses. Yes, it is a fear, but you don't have to buy the glasses. You have to go to get your eyes checked. So you get your whatever the condition is that you catch it earlier. If you catch it earlier, the treatment is earlier. Again, as you rightly said, breaking the cycle of understanding and the fear complex, it works. Thank you. I can go on for hours, honestly, I tell you.
Yeah,
Thank
just want
you.
to add to
But
what you're
again,
saying.
before I go, you can have this, the instruction how to put the eye drops in. So probably I'll send you an email, or if you can just put your email to me, I will send that Word document, and just you can distribute to people.
Thank you.
Thank you, Subhash.
Thank
Thank
you.
you for your contribution.
Pleasure meeting you.
Be patient with the patient. Take care of your eyes. Eyes are very important organs. So, just take care of your eyes, which is beautiful. Let's move to Neetu, who is going to
Oh,
give,
she's brilliant.
she's going to give her perception of how we can have affordable nutrition plan in this Universal Health Coverage Day. And Neetu is also a holistic health nutritionist. She nourishes the body with mind, spirit as well. So it's just complete 360 solution that she will provide over here. Global namaste to you, Neetu, and what have you got lined up for us today?
Global namaste, everybody. Thank you for having me. So I'm Neetu Pasricha. I am AFN registered nutrition and lifestyle consultant. Thank you for introducing me. And thank you everybody for amazing presentations. I have learned so much already today. And I completely agree with Dr. Subhash and Dr. Kailash and Dr. Damayanti. I also highly believe education or awareness is the first step to prevention of disease. We absolutely need more health education, health awareness, and I'm all up for this. And community level support or community level awareness. And like Dr. Subhash said, I'm also high believer of tailored approach. So I work a lot with community health services, and my background is community health services as well. So I make sure that the awareness content or the talk is tailored to local community. Otherwise, there's no point, because we can't expect people to understand if we are not tailoring it down, if we don't understand their perceptions, their perspectives. So like Dr. Subhash very rightly said, empathy, compassion, really, really important to me as well. So I definitely make sure this compassionate approach, because we understand there can be a lot of fears, stigmas attached. People might have fear to be judged. And I mean, nobody chooses to be ill. Nobody chooses to get any disease, but sometimes things happen. So when they know healthcare professionals are going to offer empathetic, compassionate support, they are more able to trust, open up their hearts, and talk to us and give us the true picture of what's happening in their life. Because when we talk about disease, the reason I look into holistic approaches because they are wider factors to health. So it's not very straightforward always. And when we cover all aspects of health and well-being, so nutrition, the whole lifestyle area, and also habit forming as well, because there can be reasons why people are limited with their habit changing. So the whole holistic approach and the whole person-centered approach tailored to that person's needs, preferences, cultural preferences, really, really important. It's heart of healthcare system, I would say. I also agree with training our healthcare professionals. So again, as a nutrition lifestyle consultant, I also develop, deliver, and evaluate trainings as well. So for example, I've recently delivered a training on menopause to one of the London boroughs, which is a very diverse borough. But this training was mainly tailored to Somali and Bangladeshi population in that borough. So as I mentioned, the whole content or the whole training was tailored to that community. And we have trained community volunteers, because sometimes with healthcare services, we need to think about this to get community involved in it. It helps with community strengthening, cohesion, mobilizing community and people helping and supporting each other. Also gives them that feeling of belonging. And sometimes, having community volunteers, we get really good picture, really a good idea of community perceptions there. What are the limitations? What are the barriers? Are there any stigmas, any fears around these things? So that really helps. And the whole training was tailored, and we are still working together. I'm still kind of mentoring them. So it's working really well. So my practice, although I'm a freelance nutrition and lifestyle consultant, but because of my vast background in NHS community public health services, my heart is still with community health. So I like collaborating with NGOs, local authorities, private, public sector, and raising awareness. Very, very important. Like Dr. Subhash very rightly said, I find the same. People sometimes don't have basic awareness or knowledge on subject, and that can be the barrier. Sometimes there can be basic fears around, and that can be the barrier to access services, not necessarily that the services are not available. Maybe it's the fear of being judged or some other barriers. I mean, yesterday only we were doing kind of promotion for charity, which we are together doing events for cancer patients. So it's for patients who have received cancer treatment recently. So within 3 months, we are trying to organize survey events so we can have community people coming and telling us what sort of cancer services they would like in the area. So I absolutely highly believe in this kind of collaborative, collective approach to health and well-being, where all of us, healthcare professionals, community, individuals, organizations, we all come together and we try and identify disease at early stage, so we avoid delays, because delays, as we know, can make things even difficult, and prevention. So when I did my study, research project that I did, that was again looking at effect of COVID on health and well-being of Bangladeshi population living in Java Heights. And my research also highlighted that although there were healthcare services there, they were not aware of it. So sometimes it can be these things. People are not aware of what's happening in their locality, in their community. That was one of the things that highlighted. And then another was, of course, about a lot of stigma and fear attached to this. So fear of being judged because of any health condition, or not sure about how to utilize these services. So there were lots of gaps. So sometimes we might have these kind of gaps there as well. And I also kind of believe in community leading, community shaping the services, because they know the best. Individuals know their body and mind and what they are going through. So it's a good idea to get their perceptions and try and adapt healthcare services around persons, so taking person as a whole. And because we know there are environmental factors, social factors, so lots of underlying factors to disease. So yeah, my main message is collective approach is really, really important, which is non-judgmental community. Yeah, absolutely. And believing again is self-care. So yes, there can be gaps in healthcare services. There can be lack of education, awareness, lots happening in our environment. Sometimes we talk a lot about food environment, what's happening in supermarkets, what's happening around us, policies, all these things. But I also feel we all have a responsibility to our own health and well-being as well. And that starts with self-care. So if we set up a routine for ourselves, some daily rituals for ourselves, and make sure we look after ourselves, now and then take a pause, which I call is the sacred pause. Very, very important. Take a pause from whatever is happening in your life and try and tune in with your body, tune in with your mind, and listen to your body. Sometimes we listen to all this chatter around social media or people around us, friends, family, but we don't get to take time to just sit down, take a pause, and tune into our body and mind and listen to ourselves and see if it's trying to tell us something. Because sometimes that's all we need. And we might get the pathway to solutions, to answers. So I believe it's really important to now and then check in with ourselves and see how we are feeling and then take it from there. So definitely raising our awareness, because it's awareness, then prevention, and then we look into treatment. Yeah, thank you. Any questions, anyone?
So thank you, Nitu. Your broadband is very poor, so you were cutting off. If you can still hear us, I think she's gone. So Anjali, what do you think?
Yeah, sorry about that. Yeah, I didn't realize.
I think she's back again, trying to talk to
I
us.
think she's having an internet problem. It looks like it.
Yes, her broadband is very bad. We can see it from over here.
Yeah.
So Anjali, we shall.
Apologies. Yeah, I didn't realize.
It's okay. So Anjali, what do you think?
Yeah, exactly. I think, thank you, Neetu. You're doing some wonderful work around community health. I think it's so important to get awareness on lifestyle, nutrition, starting from the grassroots level. How to bring them together in a, like Dr. Swaz said about church meetings or temple meetings, and be at a ground level zero where you're communicating with their, hopes and their wants. So as he said, jambo, like a hello in African language, or you're saying namaste for the Indian people, or Kamonacho in Bengali. So it just breaks the ties, and we need to build their more communities catering to their needs, which are more easily handled, because they're very much scared to come to the hospital or talk to a dietitian. They have taboo subject. Oh, if I talk about this, she'll say, don't eat this, don't eat that. But if it's in a friendly, non-hospital based environment, they can be very comfortable talking to all of us, and we can help them better. Because when they are in their comfortable zone, it's easy to educate also. So we have to go down to their level and then educate them. That's why I think you're doing a wonderful job, Neetu and Dr. Shuaz, both of you. Thank you so much.
You have to be in their comfort zone. Seriously, I tell you,
Yeah,
and that
yeah.
makes a massive difference. Neetu was with me. I mean, we were on a radio station recently. It's an ethnic radio station, and it makes massive difference. Even they're listening to us on a radio, and the lady who actually Kiran Shah, who actually is a radio jockey, she's brilliant. The way we weave into the stories and with Neetu and even talking to them about nutrition and everything, it just goes very well. Yeah.
Absolutely.
Do you feel that the health professionals are under a lot of pressure now, either to meet targets or something, and they don't have too much personal time with people? Do you find that in India, Anjali?
Yeah, we are not able to, manage the expectations sometimes, right? Because they've got getting a lot of knowledge from all the social media, and we have certain kind of, criterias. Okay, this is what we should do, this is what we should not do. So there's a mix and match of all information coming, created fear psychosis being created by social media also. If you eat this, this will happen, this if this is what you'll do, this will happen. So breaking that, basically fear psychosis among them is very, very important for any one of us involved in community level care. And I think getting them to understand their bodies more holistically really helps them to break that fear psychosis. And yeah, it is a mix and match. I think hospital-based and community-based healthcare, I think they both need to combine together. That's when we can cater to bigger audience, bigger audience, and who will understand better. They'll not fear seeing the doctor at the right time.
I'd just like to add something here. I think it was about 10 years back. I was invited. That time my daughter used to live in Mumbai, and a friend of mine from UK had become a consultant cardiologist in Apollo Hospital in Navi Mumbai. So Nikhil invited me. He said, "You're doing such tremendous work with the patient and creating the education program in the hospital. Why don't you come and give a talk at Apollo?" Great stuff. I went there. there were about 18 consultants from different fraternity who were sitting there, ophthalmology, orthopedic surgeons, everyone in Apollo, right? You know what? At the end of my talk, it's not going to happen here. I said, why? Here the patient comes in, they always go for second or the third or the fourth opinion, number one. And then they will go to the village Vaidya and get, but, you know, whoever, and get the treatment from there. And they all mess it up. And I tried to tell them, yes, in the UK also, you know, when I started this patient education program, I had a lot of resistance, different way, because here is NHS, so you're going to be there and there with the NHS, you can't go anywhere else. Yet, the resistance was there. You just engage with the patient. And I thought Apollo Hospital, we've got such a great consultant over. Only thing what you need to do, create an education program in the hospital, offer them a cup of tea or a dosa or whatever, or a samosa along with it, and people will flock in. And you're making them understand what the process they'll be going through in the hospital. It didn't work out. Just didn't work out. I do try. Yeah.
Thank you.
Okay, Amrita. So we were discussing about patient relationship and how different countries behave differently, and one has to be a bit empathetic with the patients as well, and how nutrition can
Yeah.
maybe help. So Amrita, while you are there in India, of course, and you also, of course, practice there, do you feel Dr. Google has actually spoiled things and, everybody Googles up, and now with the AI, each one of them comes as an expert, they've diagnosed themselves already, and then they want to educate the expert they are talking to because they come to see a consultant through a doctor. Do you think it helps? I mean, it's okay. It's nice to help your consultant by giving them what happens to you, or what happens to you when you have certain diet, or what happens when you wake up, or what happens at night. So give some data so they can analyze. Do you think this Dr. Google and technology has actually messed people up as well?
Yeah, of course. What I wanted to say was like experience is a very big thing in life. And so the doctors and the professionals who are sitting on the chair have an experience that the patient doesn't have. And the experience that Google gives them is just a very theoretical mode of the possibilities of the kind of symptoms and the kind of disorders and likelihood of the things, which as a tendency of the mindset of an individual and the fear of not getting a particular disease or getting sick, a patient generally clings to. And with that mindset, there's a um, lot of, I would say, a biased opinion that people make about themselves, which in fact troubles a lot of systems. I would say that is why there's a lot of other talks in relationship of how to use AI in a healthy way. And that's very important. But in today's time of understanding and giving affordable health solutions, to some extent, I would say 1% it might help you. Yeah, you have got a sore throat, you can have some warm water, some holistic tips, and some herbs and some other stuff, or take some medicine. But then ultimately the clinical symptoms, only a physician who is um, knowledgeable and experienced, I would say, would be able to give. On that note, I would also like to ask a question to Subhashji. Subhashji, you have been into the pharmaceutical industry all the way long.
Yeah.
So, what is your take on understanding and the role of pharmaceutical companies in giving affordable and unaffordable health solutions to the world? Over to
I
you.
think, yes. Okay, I have worked for three really biggest pharmaceutical companies. And
Mm.
my last tenure for nearly 20 years was with Merck Sharp and Dohme, MSc, a research company and all. Now we have to understand two things here. And I'm not talking from the industry point of view, I'm talking from the development of a drug.
Mm.
So
Drug development.
we pick up 5,000 different molecules and then arrive at one molecule which is beneficial, non-toxic, and relevant, the treatment part of it, right? So it takes about nearly 12 years to develop a molecule. So there's a huge amount of research and money which has gone in, number one. So
Mm.
then the company gets a certain period of time to sell it as a branded product. Hmm?
Mm.
Okay. Now this is when the branded product comes in, then we say, for example, I worked in different areas like in ophthalmology, in cardiology, in pain management, you name it, and I worked in different areas. What we actually try to, when we speak with the doctors, I'm talking from MSD's point of view because we had a completely different sort of psyche built in this company. That the medicine is for people. The people are the first people. You have people in mind. That's the way you go and promote your product. So what we used to do is we identify a certain area. Say, for example, in diabetes, you identify, okay, hypo is a very big issue here, hypoglycemia. And what causes hypoglycemia? So you look at two things, patient's condition or the dietary habits, etc., plus a very commonly used sulfur, a product, the cheapest one, which was being prescribed first. Now that caused hypos. Now when a hypo was, I'm talking from England point of view, right? So if a hypo is caused, ambulance comes in, patient gets taken to the hospital, gets treated, stays in the hospital for at least 12 hours observation. You know the total cost which was involved? £1,200. That includes everything. I'm talking about patient being taken from ambulance, cost of the ambulance going into the hospital and everything. So when we looked at the whole economics part of it, then we felt, okay, if we have a product which will not cause a hypo, how would it work? You see the health economics? Now, this is where
Mm.
people do not understand the research-based pharmaceutical companies. They think, oh, they're out to make money. Yes, we have to make money because we produce another product for coming into, and that's how the development takes place. Now,
Mm.
after a certain period of time, the branded products goes into generics. I have no issues with the generics, provided they stick to the norms. Now, give you an example. Pharmaceutical generic product, if you look at it, the main drug remains the same, but you can twist the constituents, the other thing. Now, this is where the problem starts because generic people to make it cheaper or affordable, I will say not cheaper, affordable, there are lots of shortcuts are there. And this is where the problem lies. So this is the big difference between a branded product and a generic product. Some of the generic products are really, really good, honestly, I tell you. And I would really go after the generic product as well. But then they are from a standard, really, definitely a good company from themselves. So you have to understand these whole vagaries of the research, actually the cost of the research, at the end result where you get, and then the patient's benefit which you get. And this is how the whole thing works. I mean, I remember we had just introduced a sitagliptin, which is for diabetes type 2. And that was during the Ramadan time over here in Kent, where I was working. I went down to a GP's practice where I was going to talk to the diabetic nurse. And then when I saw outside, there were taxis there in Chatham area. There were lots of Muslim drivers at Chattington. It just, I always like to think outside the box. So when I went to the nurse, and I had just asked her that, do you have lots of people having accidents or hypos among these, especially taxi drivers? He said, Subhash, why are you asking me this? Then let's have it. So she took out from her computer and she
Mm.
found that last year they had about 120 hypo-related incidences. and especially with the taxi drivers.
I
Now,
see.
you see the whole thing. So it was
Interesting.
yeah.
Hmm.
So then we looked at the prescription and we found out, they're fasting, number one, and then they're taking this tablet, which is causing hypos. The whole
Hmm.
thing, and then we moved to, okay, if there's a product which was not causing a hypo, how would it work out? It worked absolutely brilliant. So these are the nuances which I'm talking about. So when you prescribe, even as a doctor, you need to look at again the ethnicity, the whole, the side of the patient, find out exactly what it is, and then go ahead with it. Does that answer your question?
Yeah, to some extent it answers my question, but in different countries, different issues in terms of health economy, I think, is there, as well as in terms of education, sustainability, sustainable solutions towards health, solutions, population, rise and control of different kind of diseases that are prevalent in a particular country, and the requirements as per the particular population and that diaspora is also varies. So please
I
stay
was in
around.
India
We'll
in
be,
Yeah, I
yeah,
was in
so
India in February, and I studied in Ahmedabad, my pharmacy college. I was in Ahmedabad, and then I do go down to my college whenever time permits, etc. And there's a group of friends who invited me to give a talk, and especially you say you are working in eye drops, and so let's talk about cataract. So okay, explain about cataract. You know, the misinformation which prevents India. Everybody says, "Oh, I have done my cataract with laser surgery," and I said, "What's that?" There's no laser surgery in cataract surgery. It is phacoemulsification, right? But people are charging 100,000 rupees just to say it's a laser surgery I had. I had a friend who said, me, "Oh, I had a laser surgery." I said, "No, you didn't have a laser surgery." When I explained it to them, oops, you understand this? But the main thing was the aftercare. Those two eye drops, the chloramphenicol, the antibiotic, and anti-inflammatory steroid. And people were not using it correctly. And that's why the inflammation carried on. There was an issues after the healing was not there. And then you start blaming the consultant or the doctor.
hmm,
So uh, just lastly, here in Gillingham, there is a lovely Punjabi Sikh girl who
hmm,
has created Sahara program for elderly Punjabi diaspora, right? Who can't speak English very well. They're all about 70, 80 people. They don't get out of the house much and all sorts of. So she, Paramjot is doing brilliantly well. Her mother, yeah, cataract. Now, me being me, I've explained everything and all that. But then she went to Amritsar for darshan. Comes back with an eye drop, right? Baba Ramdev's or Drishti.
yeah.
You know why I've lost my hair? I keep on pulling it. Seriously. So when
That
she
Dr.
came in,
Ankul is also
her
asked
daughter,
actually.
yeah,
Correct.
her daughter Paramjot before, and she started using it in India, right? And it was burning. She had inflammation of the eye and all that. And then Paramjot comes in. She, this is at 9:30 in the night. I get a WhatsApp message. Subhash, please, can you explain this? I said, send me the photograph. I looked at it and I was livid. You know what that contains? You should explain it to your patients when they. Drishti costs 23 rupees, a 10 ml vial. Okay.
Hmm.
It has got
Yeah.
extract of onion, extract of ginger, lemon, nimbu ka ras, honey, and benzalkonium chloride. This is a lethal combination to destroy the eye. And he promotes it under it cures everything. Glaucoma, jammer, cataract, you name it, it cures everything. It doesn't cure anything. It ruins the eyes. I've taken it to the health minister in India. No. You know what I was told? He's too powerful. Please don't enter into this. Uh, I was furious. I've even spoken to Professor Danda, who's the AIMI's top gun in Delhi. And he told me the same thing, Subhash, just don't go there. It's the only thing what we can do, tell patient not to use it. That's it. It's a minefield. Um, it is a minefield, honestly, I tell you.
Thank you. Let's move on to our Dr.
Yeah.
Anukul Goswami, our resident host over here, who is over the next hour bringing three experts who will bring different perception. Thank you, Subhash. Stay around if you can, and we can chit chat again. Over to you, Amrita.
Thank you very much, Subhashji. Thank you.
It's a pleasure.
Namaskar.
Bye-bye.
I think we were just discussing a very important issue about the healthcare economics. It's a very important part of any healthcare, because one of the things as doctors we have is that we have to make sure the resources are appropriately distributed in ways which are legitimate and also at the same time ethically correct. So if I use one set of money that is there in the pot of the healthcare and I use it for one particular person in a big way, obviously other persons don't get it equally well. So we've got to make sure that we are very careful in our distribution of money. Therefore, as senior managers and consultants, we have to be making sure that the healthcare costs are equally distributed. One of the ways of determining healthcare cost is to find out when the GP is referring the patient from home and the patient is coming back home, how much has the cost, how much has it costed to get the patient back home, and what has been the amount of the change in the difference in health. So there's something called quality of life assessment before being sent to the hospital. And when the person comes back home after the treatment, there's another quality of life assessment. And the cost, the difference between these quality of life and how much it costed to give that change in life tells you the fundamental how much it cost for take care. But the reality comes that there are two concepts of healthcare. One is a direct cost, what you're spending for the healthcare, but indirect cost. And many people forget this indirect cost. For example, the patient has to park the car in the hospital, go or travel in the taxi and other kind of things. But there's also another indirect cost to the healthcare economics. And that is when the patient takes leave from his workplace, cannot go back to work for X number of days after anything, whether that be a problem, an injury or an operation or whatever it is. But the person, when he is not able to go back to the work work suffers one way or the other. They have either got to employ somebody else, or many of the things that are left around not being attended to. So they all cost a lot to the economics. So indirect cost to economics is quite heavy, much heavier than people normally take into account. That's one of the things that majority of the doctors will like to always look into and make sure that they're able to address it. So I have one of the things that we have is what do you call? There is a very nice book by Michael Porter. This came out sometime in 2002 called The Redefining Healthcare. I don't think I'll see it properly. Redefining Healthcare. It's a good 800 pages book. And he collected the data from all the insurance companies in USA, how much it cost to provide various care. And what he found was shocking, that the same condition, 10 different doctors get 10 different opinions as to what should be done, what should not be done. And he says, why is it that a particular neurosurgical procedure is advised in a state A in USA and not advised in state B in USA? What are the changes and why are there differences? So those differences in things have been taken into account. And you'll find the complication rate in one hospital is different. Although the same people have undergone the same training in different hospitals, the training can be quite different. And therefore, healthcare economics, he studied very extensively and found some very peculiar problems. And there's a very interesting thing which have come out over time, and that is that an early and accurate diagnosis is very, very vital. So you have to have somebody who is competent in knowing exactly what is going on. Therefore, if you go to 10 different doctors or 5 different doctors, you're actually creating more confusion in the system. Number 2 is that you have to have early targeted physiotherapy. Particularly, I'm talking in orthopedic practice. I'll be getting into Mr. Swami very soon. But in orthopedic practice, you have to have a very clear diagnosis very quickly. And the use of physiotherapists, other people, can be easily done and very nice. If you're a competent doctor, then what happens is, a competent surgeon in particular, you will know that this particular person is likely to get better with physiotherapy. You can send the person to the right physiotherapist. Mr. Krishnaswamy will tell you also in that he has had quite a bit of interaction with physiotherapists. who have been able to cut down on the operation theatre list by giving the right therapy in the right time while they were already on the operating list. Then we have to limit the overuse of injection, other kind of steroids for our conditions. Then it should be ideally done through one-stop integrated care. So in other words, person comes in one place, you have got the clinician seeing the patient, a physiotherapist seeing the patient, undergoing the imaging very quickly and sorted out as fast as possible, rather than getting multiple appointments for different things. Then that cuts down on unnecessary in this thing. Then you have to empower the patient. Now, this is a very subtle point. And I'll tell that to you. You must have heard of something called evidence-based medicine. Evidence means you're trying to say which particular method of treatment or medicine is the most effective in managing a particular problem. But you might have an evidence to that a particular drug is effective, but in the other way, the same drug may cause some side effects which are not very necessarily helpful to the patient. So that is what we call is a value-based medicine. That's what particular condition is most valuable. It might not reduce the blood pressure a lot, but if the person is sleepy the whole day, even if the drug is very good, he cannot work at work. So that can be cut down. You might have a little less potent drug, but at least the person is able to work. So that's value-based medicine. But there is third thing which is very important, something called narrative-based medicine. Now, let me give you an example of value-based medicine as opposed to narrative-based medicine. A value-based medicine was, I remember I was to operate on a particular patient. I went to the list and suddenly I found that there was one patient who was referred by some other clinician to my operating theater, and I was to do the knee replacement surgery. So this person was a Pakistani person who was Muslim, and he needed to do his prayers and namaz every day. So, well, I told him that I had not seen him before. So I asked him, are you happy to go ahead with the surgery? I said, do you know what complications you can have and things like that? So then I asked him a very straightforward question. What do you want the knee replacement for? His relatives from Pakistan had come, everybody had come to that place. So he said, no, I just want to be able to sit down and do my namaz properly. I said, that's something that does not happen properly with the knee replacement surgery. You will still have restricted movements. You cannot get a full flexion. And not only that, we make a scar in the front of your knee. It's going to hurt. So he says, oh, in that case, I don't want. So you see, and then he said, I'm happy to do my prayers on a chair, but I don't want this knee replacement. And that's a very important value that you want to give with a knee replacement. But if you can't give it, don't do it. Then there was another narrative-based medicine, a very simple affair. There was a lady who had been assessed by a whole lot of surgeons and clinicians and at different times and had undergone MRI, ultrasound scan, but the patient was having some impingement in the shoulder. She was just about 74 or 76. So it was for 3-4 years she had been ongoing. So I said, what is your main problem? Why do you, of course, she had a solid real impingement in the shoulder, and she had also stiffness in the shoulder anyway. So I said, what is your main issue? He said, I cannot dry my clothes in my, on the particular, this thing. So I said, well, and she used to be living alone under the council. So I said, do you think if you can get the rope down, that will be easier for you? He said, oh yeah, I'm happy with that. So all that I needed to do was write a letter to the council that could you please lower the line down? And that should be happy for you. And she was happy with that. Now, the point is that in these 4 years that she had undergone MRI scan, ultrasound scan, whole lot of stuff, you have forgotten the person completely. So it's a narrative. It's a question of what is it that you really want out of intervention. So without going any further, we need to know that we have to have a standardized pathway. We should be able to understand what is the right thing to do for a given person. And you follow this particular pathway, narrative or value-based procedure. What are you trying to approach? And based on that, you can make a decision. And the person should be given a full idea as to what all can happen right and wrong. And that is, of course, you make a consent in such a way that both of us agree to have the right treatment. So I get in Mr. Krishna Swami. He is a very eminent shoulder surgeon. Why I like him particularly, I must tell you this one, because many people we live very close by. Many people who meet me and say, oh, you're Mr. Swami, you have treated my wife. She is doing very well. My mother is doing very well. So I always bask under his name. So he's a very well-known shoulder surgeon over here. Everybody knows him by name and is very popular, both as a teacher and so he has done his studies in medicine as well as orthopedics from St. John's in Bangalore. He practiced in India. He's been over here in this country for almost 33 or 34 years. 37. We were together. Sorry?
37.
37. Oh my God. So, and we did our MCH orthopedics together in Liverpool University. And I must confess that I've learned so much from him in my lifetime about, and whenever I have any issues with any shoulder patients, I run to him. I said, Krishna, what do we do? So
Yeah,
I
I think, Anukul, thank you very much. I think he's telling all the lies. I don't think you should believe any of that he's saying. Thank you very much. And I don't know what I can add because Anukul has got so much experience and more than me. I'm basically a surgeon, maybe very biased at surgery, but let's see. I'll share my screen. I got a few examples of what to do, what not to do, and hope I don't bore you with all these pictures. Can I share the screen, Anukul? Is that okay?
Yeah, please.
Something, yeah. Can you see that?
Not as yet.
I'll come back again. Sorry. I'm not sure. It's not showing, Anukul.
Are you pressing the green button that shows share?
Yeah, I've done it. It is going empty. So it says screen sharing by host only. I think you need to let me share, I think.
Yeah, okay. Nishit, is Nishit there on the online?
Yeah, it comes as
We can, yeah,
You are a co-host. You are a co-host.
please go ahead.
So you can share. Krishna
Am I
Swami,
okay to
you are
share?
a co-host. You can share screen.
Can I do it now?
You are a co-host, so you
Okay.
can share screen.
It's not coming. Oh, I'm so sorry. It's not right. While no chance.
See,
Try again, please.
You are a co-host, so you should be able to share screen yourself. If you go to the bottom taskbar with the green button.
Yeah, I have done it. I've done it before, so it's nothing new.
And look,
but what is not doing is showing my desktop. Sorry. Can I try another computer? Can you give me 5 minutes?
Yes, don't worry. We can keep on talking. Dr. Anukul, you can just still.
Yeah, okay. I will then get Mr. Purva Chakravarti.
Can we discuss while you are getting ready? I was listening to Dr. Anukul's description, and I find it really interesting that he talks about integrated medicine and to ask the patient what he actually needs before going through the surgery. So I find that in our countries, this is not yet happening, but I think it's an interesting development in medicine because in our country, whether the patient needs or not. Sorry?
That's fine.
Can you hear me?
Yeah, we can.
Please go
Okay,
ahead.
so the outcome, depending on the age and what the patient needs, that is not asked when it comes to surgery, especially when it comes to things like orthopedic surgery. So I think that is a very important outcome. Like, for example, this is where I think the traditional medicine can help because not everybody needs a knee replacement. If they can live without the pain by applying a bit of oil, for example, I think that is worthwhile instead of exposing a patient for a big surgery at a later stage of life, isn't it?
Absolutely. I think that is true. I think most of the surgeons, I mean, we say that we don't like to do operations unless and until you have come to the end of your treatment, that nothing is changing. But it's a question of a patient's understanding what all things can be going wrong. When it comes to a shared decision making, we call it, and the concept of I know what all things can go wrong, and the patient should also know what all things can go wrong. And there's a very important part in legal practice, in medical legal practice. one of the things should be very clear to the patient that you have to be aware that everything does not go on well with every operation. And how are you prepared to face the consequences? Suppose let's assume an infection occurs in, say, 1 in 200 patients. But if it does infect you, you can be affected in various ways. Are you prepared for it? So no matter how small the chance for it, for the person who gets that complication, it is one in lifetime chance. Yes, it does not happen often, but if it happens to you, are you prepared for the consequences? And once a person is able to go back and think that suppose if it does happen like that, how will it take care of it? Now, it can deter some of the patients from going for the surgery straight away or saying, oh, everybody gets an e-operator, everything will be fine with me. No, things can go wrong. Our point is to do well. Now, it has a huge impact on us as surgeons. If I'm trying to do a surgery with a specific interest to do the best for that particular patient, I don't want to see the patient back with some complication. I wouldn't like to see that. But again, it's a question of how both of us have agreed that if we do this, this can happen, and then how we can manage each other's. But it cannot be one situation that can fix all. So that relationship should be good, and some amount of time invested in describing what is very helpful for these patients.
And also, Dr. Anupol, if you can, like you were talking about a very beautiful thing, that 1 point examination of the patient. Like, I think that would be wonderful if you can introduce the traditional medicine also, just like what is
Yes.
happening in China. So even though we have all this knowledge in Asia, I think it should start from Europe or even UK or America to have this integrated approach. Then only everybody will accept it, like even though the knowledge is there in our countries, they are too scared to take that decision to integrate it. So if it starts at your end, I think it will happen really.
I think we have been working on this particular concept very, very much. Be aware that in our conventional system of medicine, we tend to use what you call very strict statistical methods of analyzing. But the reality is that life is a bit more complicated, and we use a word called quantum entanglement. There are many other issues involved in it. And other systems of medicine have slightly different way of interpreting things. But I'm quite convinced that over the period of time, with lot of collected data, things will come along in a way where we'll be able to introduce other systems. But we tend to currently work under silos. Even in orthopedics right now, you'll be quite surprised. We have got 43 different branches. You've got surgeons who will do only hand surgery, surgeons who specifically do only thumb surgery, surgeons who will do only shoulder, surgeons who will do only the neck. So various parts are involved. So this splits us very badly into different corners. So our idea is that we should be able to understand as much of each other very well and try to integrate our care. And I think I totally support the view of integrated care.
Anukul, Krishna Swami has
Yeah, are you ready,
I think
Krishna?
I'm okay.
So
You're okay now?
Now,
I think so.
Krishna Swami, you have joined two computers with
Yes,
two.
yes, I'm going to leave one.
Can you please listen to me? You have joined two computers with two sound. If you sign off from one of them.
Yeah, I have done it.
Very good. Now let me bring you on a spotlight and you are able to share it now.
Okay. Can you see it now, my slides?
Yes.
Okay, I'll start from the beginning. So that is me. I work in Wrightington Hospital. I've been there for the last 33 years. My main interest is upper limb surgery, mostly shoulder related. And most of the time I'll be doing arthroscopic surgery of the shoulder. Arthroscopic surgery. And also I do some hand and wrist surgery as well. So Anukul has asked me, can we save costs? I don't know whether we can save it, but we'll discuss it in the end. I give you some scenarios from shoulder and scenarios from hand and wrist, and you can interrupt me during the talk, or can ask me questions in the end. So this is what I was trying to say. I trained as an upper limb orthopedic surgeon and then an upper limb surgeon, working as a shoulder surgeon, and also I'm a senior lecturer at Edge Hill University, teaching students on shoulder surgery and hand and wrist surgery. So we can classify all the MSK condition into three main categories. This is what we come across. One is trauma, other one is soft tissue injuries, and then the arthritic conditions. The arthritic conditions, as you know, It's all age related. As we 65, 70 years, we're getting problem with shoulder where, as Anukul already said, some elderly patients not able to reach for things, even hanging clothes, not able to sleep at night. These are quite a difficult situation in an elderly patient. So we got to have an answer for this. Can we treat all this just by therapy, medicine, and acupuncture? It's difficult to say because each individual patient is so different. So you have to formulate tailor-made treatment for each individual patient. As one of the ophthalmologists, Mr. Sarkar, I forgot, and he got to make sure you see the patient rather than the actual jumping into treating their actual condition. So this is an example of a very young lady who is about 14 years old who had a shoulder dislocation. So the basic thing here is to do a proper clinical examination. She has got what is called a multi-directional instability of the shoulder. That means the shoulder can dislocate forward, backward, down, everywhere. You pull the shoulder, it comes out. So what is the treatment for this? This is not related. You should not jump in and start doing an operation on this young lady. Because these patients who have problems with this sort of shoulder dislocation will have a problem with their muscles as well. They are overusing the muscles which dislocate the shoulder, especially the front ones, the subscap and pec major are so strong, they dislocate the shoulder forwards and inferiorly. So they need to couple with the posterior muscles. There's the supraspinatus, infraspinatus, and teres minor. These patients will benefit only from physiotherapy, because if you did any operation, they'll redislocate again because their ligaments are so lax. So never ever consider an operation on a young lady who has got a multi-directional instability. That is my first message, because we come across very young ladies with subluxing shoulder. We don't examine them properly. If you examine them, wrist, knees, and hips, they're all very lax. So surgery is doomed to failure. So one has to be extremely careful. Although they come with the perception of a surgeon saying that, okay, you need an operation, we'll make it better, and it won't work. That's my experience. I'm sure Anukul will also agree with that. So that's one example of when not to do an operation. So next, going into this, an elderly lady, I think it's a gentleman of 52 years, who has got this very badly broken right shoulder. He works as a builder and he has to work throughout the year. As you know, that the winter is the busiest period. So he walked on this snow, fell and broken the shoulder so badly. So here, there's no choice but to operate on them to get back to their get back to their builder's life soon, because otherwise he's self-employed, he'll lose a lot of money. So here there's no choice but to consider surgery. So as you can see, these two are two different scenarios. So again, you have to go by the needs of the patient, tailor-made operation for them. And this gentleman, after 6 months, was very happy, went back into his building and then building industry and was doing very well. So these are a couple of trauma cases. Now, coming into the normal problems we experience after 45, 50 years old, even in young patient and somebody who's getting into their 65, 70, is what we call, what we have is the ligament tears, rotator cuff tears, and AC joint disruption. So rotator cuff tears are very common. If you analyze or scan about 100 patients over the age of 65 to 70, about 27% have some sort of a rotator cuff tear. That doesn't mean all these patients need operation, but rotator cuff tears are common. If this happens in a young patient, like it's quite commonly see rugby injuries with large rotator cuff tears. These guys need operating, but wherever reaching the age of 60 to 70, where they have got impingement syndrome with a small cuff tear, doesn't need an operation. They need adequate amount of physiotherapy, changing their muscle patterning actions of different muscles, and they do tend to get better. Ligament tears are quite common in young patients who have recurrent dislocation in shoulder, and especially if they are into like a sports person, I tend to operate on them. But over the age of 50, 60, 70, it doesn't need fixing the ligaments as much, because they are not required that much. But cuff tears can be difficult to manage even in elderly patients because their main problem is weakness. They can reach for things, but when they reach for higher up and the arm doesn't stay there and it just drops down. So if there is a significant weakness, I do consider a surgical approach and do a arthroscopic rotator cuff repair. So obviously we need to do all this investigation. The main thing is, as Anukul said, clinical. Everything is clinical. As I said, weakness is the main problem. X-ray may not show anything. MRI scans may show a significant amount of tear. Obviously, we try conservative management, which is physiotherapy, anti-inflammatory medication, maybe a couple of injections. If nothing works, then surgery would be the best option for them. And provided the tendon substance is good, we get a good repair. If it's not that good, they may just end up having what you call an arthroplasty procedure later in later life. So again, tailor-made surgery for each individual patient. Oh, sorry. So this is just an example of just going back to the arthroscopic rotator cuff repair, which should take not more than 50 minutes to do. And I do it when the patients can be awake. Sometimes they don't need to be asleep. They can be watching their operation on the screen. And as I said, 40, 50, this is a simple tear which didn't take too long, about 50 minutes procedure. And then they are awake, they can go home the same day. And so that reduces the healthcare costs of staying in the hospital. A physiotherapist sees them straight after surgery and they know what to do. And then around 4 to 6 weeks time, they should get decent amount of power in the cuff, but it usually takes about 6 months for them to get full range of movement. Although I would not believe all patients do get full range of movements, at least about something for them to reach for a cup of tea or reach the shelf to pick up like a coffee or a sugar or any bottle from the shelves. Again, going back, 40% of the tests need not need any surgical intervention. They can be treated with physiotherapy. So as I said, I'm just biased about surgery. If I see somebody who's very weak, even at 70 years old, 75 years old, they're quite active, or their rest of their health is satisfactory, I do consider surgical approach. And if they are not so well, like respiratory problems, I can still do it under awake surgery, under nerve block in the neck, what you call the suprascapular nerve block. And it works very well. And I only need 50 minutes to do this. So what I want from the therapist, if there are any therapists here, to send these patients early. Although I know that they had to go through X-ray scans and other stuff, but early referral when a particular shoulder is very weak in elevation and external rotation. So they need to come fairly soon. So finally, we see this mainly a very severe glenohumeral osteoarthritis in a patient who is about 64 years old. You might see there's absolutely no joint space left. I don't go through all the CT scans and all that. This is one example of where you cannot ignore. She has tried injections, physiotherapy, intra-articular injection by myself a couple of times, although I said the joint space is so narrow, she may not get any better with injection, but she wanted to try a couple of injections, didn't work. So she finally underwent a shoulder replacement. And she's very happy. She's gone back playing tennis. I can't believe that, but she is. So certain things we cannot ignore and certain things you can delay. So this is the operation she had, what we call the reverse shoulder arthroplasty, because this age group, what I believe is the tendons may not be working satisfactorily. So we do the reverse shoulder arthroplasty, mainly relying on the deltoid muscle. And this has become more and more popular now, although started in France about 25 years ago, we have taken up in the last 10 years. And most of, if you compare, if I can say, anatomical shoulder replacement versus reverse shoulder replacement, we are doing more and more reverse shoulder replacement. And they give very good result with obviously adequate amount of physiotherapy. Wherever we go, we are relying on physiotherapists. Without them, I don't think any operation is going to be success. Also, as I said before, when I'm dealing with rotator cuff repairs, I do something called a prehab. That means get their muscles activated 6 months before the cuff repair, and then do the repair so that we can rehab faster. So physiotherapist is the mainstay with all these operations. So I'll just come to very quickly some hand and wrist trauma. So this is a very badly broken wrist. Obviously, this is what you call involving the joint, or what we call an intra-articular die punch fracture. This cannot be ignored. This is in a young patient of 24 which need an operative treatment. I did put a plate and some cross screws to hold it together. But the problem again is rehab them. Rehab them is very important. My job is about 45 minutes to an hour, but the therapist has to see them almost once in a fortnight here. At least they spend about 30, 40 minutes educating them. As Mr. Sarkar said, sorry if I'm getting the name wrong, that educating the patient is very important after any surgery. And I do believe in my physiotherapist. And luckily, we got very good physiotherapists, both hand and wrist therapist, as well as shoulder and elbow therapist as well. And they are exceedingly good. And due to their efforts, I get credit. So physiotherapy is again essential to all this operation. So we, as we all know, we got carpal tunnel syndrome. Everybody has in their life suffered with some nerve-related problem. Carpal tunnel syndrome is so common here, common in diabetics, those who have hypothyroidism, and initially treated with the splints and injections. When everything fails, we do surgical intervention. Again, long-term splintage and physiotherapy and injection could help carpal tunnel syndrome. My objection towards injection is that if you keep doing injections, they can damage the nerve, and we may end up irreversible damage. I say nerve conduction studies, which is an added cost in the NHS for carpal tunnel syndrome. Although carpal tunnel syndrome is a clinical entity, can be easily diagnosed. And earlier time, if you ask me 20 years ago, I'm sure Anukul would agree, we never did nerve conduction studies, but we did carpal tunnel surgery on clinical grounds. Now, the nerve conduction studies are so essential, because if I did not get the expected result from carpal tunnel surgery, then I'm not justified because I did not do a nerve conduction studies. So it is not justified. So hence the reason, it's more like a defensive thing. And so we have to do a nerve conduction studies if surgery is required. Unfortunately, they do take time, they do cost, but this is what we are dealing with. So not much. Finally, couple of other conditions. This is the Dupuytren's contracture. Obviously, early Dupuytren's contracture is well treated by physiotherapists. The easiest at this stage, where there is a cord running from the mid palm into the finger, causing a flexion contracture at the interphalangeal joint, proximal interphalangeal joint. This can be easily treated with what we call a needle fasciotomy. That is not really doing a major operation. Under local anesthetic, under local anesthetic, numb this area, and using a fine needle, do multiple punches, and the finger gets straightened. This is very, very less expensive, although it's a procedure rather than an operation. But obviously the finger bends further into the palm, then one has to consider a surgical intervention. So early Dupuytren's contracture can be picked up by the therapist. They can be splinted. But the Dupuytren contracture is a resistant condition. With time, over 10-15 years, it tend to cause more and more flexion contracture at the MCP or the proximal interphalangeal joint. So finally, this is a common problem we all face as we come to the age 50, 60, 70. The thumb started getting start to get painful, especially elderly ladies who are not able to open and close bottle caps. The grip is losing, so something has to be done. So it's a very common condition. It can be treated with splintage therapy, again, 1 or 2 injections. But as you can see in this X-ray, this is very advanced osteoarthritis. Currently, we are doing a joint replacement on this at Wrightington Hospital, what you call a touch replacement, where I don't know whether you've seen a Charnley hip replacement. It's very similar to that. A cup and a ball. The ball goes into the metacarpal and the cup goes into the trapezium. And it is working so far satisfactorily. I've not done that many. My first one is next week, but my colleagues, hand and wrist surgeons, have done about 100 so far, and the results are reasonably good. So on that note, I think probably one more slide. So prevention is better than cure. We all agree on that. Most conditions can be managed conservatively. Only 30% need tertiary referral and surgery, and hospital costs and unnecessary investigation need to be justified. Young patients with family who can't afford to take time off for a long time will benefit from early management and referral. Thank you. I'll stop sharing screen and.
Thank you very much, Krishna. I mean, while going through the slides, so many things came in flooding in my mind.
Right.
When we stood together trying to do the open procedures for the rotator cuff tears,
Correct,
this would take 2.5 hours. And nowadays you finish it in 35-40 minutes. So
yeah,
it's amazing speed.
you've done that many now, so it doesn't feel like it's
exactly.
It's that difficult. But as you know, we also struggled in the past, not able to, even to pull the tendon towards the tuberosity was so hard.
That's right.
And we did not have this amount of sutures and technology, so anchors at the time. We only had size 3 Vicryl sutures. So we had to get the cuff into the trough in the greater tuberosity.
So that's exactly the point I was coming to, is that from the time that when we used to be working 30 years ago and now, so much has changed in terms of technology.
Yes.
So the question is, the speed of doing the work properly, at the same time the technology coming in. Now, how expensive is the technology is something that we're going to work at. And that as the time is going by, and we had a meeting today on AI, how it can detect those issues much earlier and we can manage the things much faster. But I think your caution that you've given us is very, very important. The right clinician to make the right decision at the right time. And that's not an easy process.
Yeah, tailor-made surgery. We all agree. Yes. If I want something done, I want the right person to do the right operation.
Now, another point is, Mr. Swami is, by the way, one of the most required surgeons, because he's also the chief advisor and the physician for the rugby players here in Wigan.
Yeah.
So for the Wigan rugby players, he's the person to make sure that everybody goes to play the rugby match well. The next is
anyway, all this rugby player wants day one operation. Straight away from rugby field into theatre.
Yeah, exactly. Straight into theatre. So he's the well-known person over here because he's part of the Wigan rugby team over here. So unfortunately, I'm not a very big guy for the rugby players, but you can get anybody keen to get some rugby, the free tickets, please ask Swami. He always has lots of them.
Right? Not sure I can get free tickets. I'll try.
Right. Physiotherapist, I cannot emphasize much more than the fact that both of us depend so much on the physiotherapist and occupational therapist to get our patients together. We just do our bit of surgical work, but I must tell you, behind all success are these physiotherapists. And I think they take away at least 80 to 90% of our work. Unbelievable. And we do not do what they do. This becomes fascinating amount of work. So now let me put it like this. He's from the center, which has introduced hip replacement in the world. Charley hip replacement. It is a center of excellence, and whatever implants and other kind of things that they are doing is absolutely on the top of the notch surgeons and implants. Anyway, thank you very much, Krishna.
No, that's
Now
okay.
I'm going to get the next very, very important person, Apurva Chakravarti. He is an occupational therapist. And oh my God, I mean, as I was just telling you, they're the people who keep us going, because without them, we just are useless. So he is a rehabilitation expert, worked in India, he's practiced from India. Then over here, he has worked in the NHS, and he is now doing even private work. He's got the most difficult job. The most difficult job, you might say, is nerve injuries, brain injuries, spinal cord injuries, and rehabilitation. And he's one of those experts. And I can tell you, for me, he's a mystery. I don't know how he does it, but he's the director of these therapy centers. And Apurva, please go ahead, give your advice to us as to how we can. I mean, the rehabilitation services are the most difficult jobs to do, and how you uh, get around it. How do you make it cheaper for everybody? And the patients are not somebody are taken care of in 2 days or 5 days or 7 days. They can go on for years, and it's a very, very involving activity. So please go ahead, Mr. Purva Chakravarti.
Thank you very much, Dr. Goswami. I think you've probably overstated some of my very modest sort of contributions to the society, but listening to all of you, you've had such a vast experience in healthcare in various different capacities. I was listening very with a lot of interest, obviously, to Dr. Goswami, but also to Dr. Swami as well. Very similar sort of sounding surnames there, but it triggered that memory, because I used to work in hand rehabilitation, and one of my background is as a hand therapist. So it always gets, so hand and brain are two areas which makes me feel very excited about. Still, even though I have, in addition to the clinical aspects of rehabilitation, I am doing a few other things as well to help help bring the next generation of therapists forward as well. But it is an area of great fascination for me, brain injury rehabilitation, but also upper limb and hand particularly. So I can sit with probably Dr. Swami for hours and listen and also discuss various things, how the hand moves, and how sort of upper limb functions, and the camaraderie between the surgical clinicians and the therapist is wonderful, because I can still remember the time when I did like hand transplant rehab and plastic surgical teams and orthopedic combined, and I was part of that teams that sort of followed up the rehabilitation of patients who had complete severance of hand and microsurgery and all that. So it's very exciting to hear Dr. Swami as well as Dr. Goswami. So yes. Anyway, I've got a very small part to play here, and what I'm going to just perhaps raise awareness of is occupational therapy, which is very much sort of, these are part of the multidisciplinary team of surgical clinicians, medical clinicians, as well as physiotherapy and occupational therapy. So they form part of the multidisciplinary team. So the main core principle of or the core definition of occupational therapy is it's a scientific approach to assessing human function and how human beings perform various activities that they have to do throughout their lives, particularly on a daily basis, but also what their roles are, at home, within the home environment, as well as wider social and community and work related areas as well. So as an occupational therapist, we assess and analyze functional skills as well as limitations arising from any illness or injury or any condition that can have an impact on how we perform various activities. And that could be as vital as getting up in and out of bed, going to the shower, dressing ourselves, taking care of ourselves, doing the cooking, cleaning, shopping, driving, our activities as a student or as a worker, or whatever we do in our daily life activities. As an occupational therapist, we can assess the functional skills and limitations that are imposed as a result of an illness or an injury, and then how to overcome some of the barriers and some of the challenges to increase independence as well as efficiency of performance, of how to make it easier for the person to work. And I think before even I had to say anything, Dr. Goswami and Dr. Swami gave very pertinent examples of simplifying some tasks, like the example of that lady whose washing line was slightly higher. So now, as busy surgeons, you yourselves will probably have very limited time of consultation, in a clinic and in theatre. But as therapists, we sometimes say we have a little bit of luxury of sitting down with the patient or the person and really getting to understand how they function in their daily lives and what are the subtleties and the challenges that they experience. So that was the perfect example of slight modification of bringing the line down, but increasing the independence of the person is very much what occupational therapy is all about. That's a litmus test of how functional assessment and functional and strategies or different ways of doing things could actually make a person independent. And the way the society is moving at the moment, I mean, particularly not just the Western part of the world, but also in the East as well, people are living longer. People are less reliant on family than they used to be, because they have to be more independent. People want to be more productive. So as we all move towards that from interdependence to independence based social structure, there is more need for all of us to be independent and to be self-sufficient as we go along. So therefore, as an occupational therapist, I would look at how somebody could be, how somebody could do a function or do a task by minimizing the impact of the condition or the injury, and how they can be more independent. And an example is in rheumatology, you get to see a lot of deformities in joints. You get to see a lot of weakness associated with the pain or the deformities in the joints. So how can a person actually still do the function but protect the joints, biomechanics to still be able to do the things that they need to do? Joint protection techniques, energy conservation. How can a task be done so that for example, in people with multiple sclerosis, where fatigue is a big challenge, and if a person lives on his or her own, how can they still be independent by applying some lifestyle changes so that they can still do the activities that are essential for them, but these are not curable conditions, so they have to still be able to live their lives as best as they can. So there are modifications in techniques of doing an activity. There are modifications, small aids that could help somebody to do some tasks. There are environmental adaptations that can be done as well. So I've got only a few slides to just go through. If I can share it, I don't know if you'll allow me to share. See, I'll have a go. I'll have a go now to see if I can. Is it?
Not showing the slide as such.
Not showing the slide.
Just showing Zoom. Yeah, it's okay now. There you are.
Is it okay now? Yeah.
Yep.
Okay. So I'll come from the top actually. So that's just me. Okay. Now, so occupational therapy, as I said before, is a science-based health and social care profession that helps people across the ages, really, I would say from cradle to grave, really, overcome challenges in completing everyday tasks, what we call occupation. Now, the term occupation, sometimes people will associate as job or work, but we see it as much broader. So an occupation, it's essentially role. So I have a role as a father, or as a as a son or as a brother or as a husband or a spouse, whatever. So, and a student and a worker. So we all have different roles as part of our lives. So that's what occupation means broadly, in broader terms. So as an occupational therapist, we will be, assessing those areas of our function. The core area is to focus on enabling participation in meaningful activities that are of meaning to the individual. As Dr. Goswami was saying, that somebody wants to do some prayers, so that's a meaningful activity for them. Somebody wants to look after their grandchildren, that's a meaningful activity. Somebody wants to be a student, that's a meaningful activity. So those need to be taken into consideration, and how we can help them be as best in those roles as possible. So, as I said, at a basic level, or as an essential activities, we all have to do washing, dressing, cooking, cleaning, working, doing our hobbies. And as OTs, in short, they call it in the UK and the US, we will assess any barriers that are physical or cognitive or environmental, and develop practical solutions to restore function and to restore independence, recommend adaptive equipments or environmental modifications. An example would be a grab rail strategically placed could help a person be more independent, getting on and off the toilet or getting in and out of a bath or a shower. It's a simple thing, but can make a difference as well. The scope is wide. So we work in physical disabilities areas, neurological conditions, as Dr. Goswami was mentioning, for mental health, learning disabilities, as well as elderly population as well. But we also work in pediatrics as well to help facilitate the child who is lagging behind in developmental milestones to be able to achieve the developmental milestones. There's a big work that goes on in pediatrics that occupational therapists contribute to help a child develop forward towards their developmental milestones, whether it's to do with developmental milestones of rolling, sitting, standing, walking, or feeding, or social participation, via play and various activities. So we work across various settings: hospitals, schools, housing, social care, voluntary and private. So the ambition is to improve somebody's function, independence, as well as the quality of life, and enable them as far as is possible and practical to help them be as an engaging social member of the society as is possible. We try to see beyond the diagnosis itself, as because the person is more, as both the surgical experts were explaining, that there is a diagnosis. It's very important to get the diagnosis early as possible, but also the uniqueness that each individual brings. There's no two patients with the same diagnosis will either have the same function or the same outcome all the time. So where is the variability? The variability is the person himself or herself often, because you can keep the medical variable under control, but you've got this person that you've also got to take along, that you've got to enable them, and that's where some of the differences can be made. That's where some of the results vary as well. Research is there to show that with OT intervention, daily functioning can be improved and reduce hospital admissions or readmissions, like revolving door that we know about in the UK. In the United Kingdom, there is National Health Service, obviously, and local authority services that provides occupational therapy, so people can go to their GP and request a referral, or the local social services have provisions as well. There's obviously waiting time with the pressures on the NHS. There's home-based assessments for mobility, safety, and independence, provision of equipments, wheelchair aids and equipments. There's a big work going on for falls prevention in elderly. It's a big issue because as they're vulnerable to falls, ending up with fractured neck or femur, head injuries, etc. You can imagine the cost, the additional cost on the health service and the pressures on the health service if an elderly person falls. It's not just a fall, it never is a fall if it results in a catastrophe. If it results in a serious injury like a fractured neck or femur, there could be further domino effects, complications. So prevention is better than cure, as Dr. Swami was also saying. Cognitive rehabilitation, as we were saying about brain injury rehabilitation, there is so much work is being done to help a person after a brain injury to be able to rehabilitate in the community, to be able to function and regain as much function as possible. There is, to some extent, the biological recovery, neurological recovery, but then to maximize that, you have got to be able to engage in activities in the right way, to be able to translate that recovery into functional benefit. Because I'll give you a very simple example so you can see the difference actually. So if you go back to the basics of a child learning a skill or a sport, unless the child practices that, no matter how much time I can spend to teaching, theoretical, didactical teaching, I can't teach somebody to ride a bike, right? I can't teach somebody to swim by telling them. So it's by doing the changes occur. That's how we learn. So that just gives us the key that how the brain has the capacity to learn function. And so similarly in rehabilitation also, we use the principle we use is the same, is by practicing in the right way, you can achieve function more wherever it's practical and possible within the limitations of that, obviously. But just to give you that idea, also some of the sensory integration work or sensory work that we do has an impact on anxiety and also other sort of more neuropsychological issues that we see after brain injury. And we know that certain sensory input has an impact. For example, vestibular sensation and other sensation has a calming effect. I mean, going back again to my very simplistic example, we rock a baby to sleep, and that's a sensory input we give to calm the baby down. Help the baby soothe, calm, and that's just a very simplistic example, but you get the idea that sensory sensory input can be used for benefiting people as well. So there's a lot of work being done both in pediatrics as well as in adults as well in the area of sensory integration by occupational therapists. We, as I mentioned before, we worked as a team, multidisciplinary, along with colleagues, physiotherapy, surgical, medical. We also work in various charitable organizations, Age UK, Stroke Association, Royal College of OT is our main body in the UK here. So in conclusion, I would say the occupational therapist's main aim is to enable the person to live the best lives they possibly can by supporting their independence and helping them to participate in their meaningful activities. We form the part of the multidisciplinary team. It's always a teamwork, as both the surgeons have explained. It always works best when each member of the team, it works as not just multidisciplinary, I would say interdisciplinary as well, because sometimes we have to kind of take on a little bit of a joint up approach as well. So and that's how we work really. So I hope it makes sense. And if there's any question, please feel free.
Thank you, Apurva. Thank you so very much. I think you're trying to explain the whole universe in these few slides. It is amazing amount of world. Now let me put it like this. One simplest way I would say to cut down the costs when it comes to outcomes in terms of surgery that we do and in rehabilitation that people like Apurva really provide is to be able to assess the patients together. I mean, it's something because I train in an institute where the physiotherapist, the occupational therapist, we all saw the patients together. Sometimes there would be a psychologist, even some other doctor would see. Once we were seen together, we would make a joint decision as to how we're going to approach. We would say, in which case, the occupational therapist or the physiotherapist will say, all right, I will manage it up to this point. If I can't go beyond that, you take over and do the surgery that you need. So what happened was a particular patient was going through a physiotherapist or occupational therapist to one side. They would bring the patient to a certain point, along with the help of physician and other clinicians. And once you're ready, then only you do the minimalist intervention in terms of surgery and get the person out. And then everybody knows which way they are going. So idea is that particular approach is the best that I've seen ever. That everybody knows what they are doing. I've done up to this much. Patient has done up to that much. Then I do this amount of surgery, and then you rehabilitate. And these are the
Absolutely.
very, very vital way of approaching and not to work in silos. So
Absolutely.
multidisciplinary team is the best approach of handling it.
Yeah, I mean, one of the other example that comes to mind is spasticity management in people who
Yes.
with spinal injuries or brain injuries as well, or or in children with cerebral palsy as well. Is, for example, the Botox injections to
That's right.
reduce the spasticity of a certain group of muscle or muscles. You know, if the surgical team and the therapy team are quite joined up, then you get the best outcome, because you can, when you're seeing the patient actually function, whether it's mobility or whether it's use of the upper limbs, you know exactly what are the culprit group of, what are the muscles which you want to dampen, but not
That's right.
all of that. But also sometimes you can utilize the tone, the
Right.
hypertonicity towards function as well, particularly for mobility or standing up,
Okay.
anti-gravity movement as
Okay,
well.
Purva.
So
Thank you very, very much.
that helps.
I will go on to Dr. Bhavna Pandya now. She's a consultant nephrologist, and she, by the way, was the Inspiring Indian Woman of 2025. It was a national competition, and she has had huge amount of accolades because of that. She has been working for the World Kidney Day, and she's a staff governor of 3 charities, and also she's the chief of the education department in nephrology. She's the lead for the chronic renal condition here in the Department of Health, and also advisor. Then she is the chair of the BAME staff network. She's a it's a member of the Medical Women's Federation, and she organizes the annual World Kidney Day. So she's very much involved in the kidney transplantation, etc. Then she's from the Liverpool Kidney Patient Association. She's the biggest contributor to the UK Parliamentary Evidence for the Management of Migrant Families, and founder member of the Arsha Vaidya, by the way. She is very much into understanding of various concepts in the philosophy. And I think her contribution to the healthcare within the communities here, particularly in the Northwest, is unbelievable, because she's also working over the weekends after various meetings. She'll be going to various places, doing various social activities, and therefore I requested her to see if she can give us some ideas to how to cut down the costs within the NHS. Are you okay, Dr. Bhavnaji? Can you hear us?
Connection. Can you hear me?
Yeah, we can.
My Zoom has gone. I don't know. Can you hear me now?
Yes.
Okay, it has been a real bad connection. Thank you very much for giving me opportunity, and thank you for giving the long list of who I am and who I am. Anyway, I've been enough in the medical practice, so probably done a lot of work in different areas. I think looking at the topic and what we're talking here is health economics, understand, and how to cut the costs down. And I think nothing better than prevention, because the treatment, we know it costs more compared to what measures we take for prevention. The first thing I would like to highlight, as an allopathy consultant I'm a nephrology consultant and I've got dual accreditation. I also work on in A&E and also on AMU. Submit, I've lost this thing. Where am I? Sorry. Yeah. So I do, and as a staff governor, can you hear me?
Yes.
Sorry, my connection has been really bad. I don't know what's going on here. So the most important point and the talk is CIP. Those who are in the NHS, they'll know cost improvement program, how we save the money. And as a staff governor, we always ask the question. So we had the annual presentation for quality assurance, and the external auditor, they were presenting. And when we asked I asked what one thing we can do in our trust to make these two ends meet, because there's always a deficit. And it was interesting that nothing more than what we are doing, unfortunately, because the cost is ever increasing for everything, every therapy, treatment, for the direct consultant involvement or MPT involvement. So we know as allopathy clinicians and healthcare professionals, we do not actually do anything for prevention. I don't think our training teaches us that much. The most we do is healthy living lifestyle and keeping us fit in a way of exercise, etc. And most of the academics, and I think you all will agree, that it is very difficult to prove what can prevent. And all the academics, they have put it down in black and white on piece of paper. Even if we do study for 20 odd years, it will be very, very difficult to prove something that this prevents. I can give you just my example. I'm a nephrologist, and for glomerulonephritis, we treat them with immunosuppressive treatment when the patient comes. Or if I have a patient who is 28, well within the normal BMI, not smoking, not drinking alcohol, completely healthy lifestyle, and still comes in with crescentic glomerulonephritis, losing the kidney and going on dialysis. So these are the things which we do not have any answers. And I always say in allopathy, we treat rather than we prevent. And in medicine, as a physician, we mainly treat the infections. The specific treatment, all the other treatment is supportive. For example, autoimmune diseases as well, what we try to do is modify the treatment. Infections, we kill the bugs with medications we give. All the other treatment is supportive, like if there's some edema, we treat them with diuretics, etc. So if you look at all the supportive treatment, that is for longer duration or along with any specific treatment we give. And for the surgeons like yourself and Dr. Krishnaswamy as well, either you replace the joint or modify something. And for those who are general surgeons, they take the tumor out or something. So the specific treatment is more focused as per the allopathy approach, unlike the other therapy like Ayurveda, which we know more about. And it is hard to do that study for 100 years also. If we do, I think Shubhasi gave some example of this eye drops and glaucoma and something. It is hard and sad that we do not have that research how to delay the appearance of cataract or glaucoma if we are following the Ayurvedic approach or something. And unfortunately, because it's a traditional medicine, people pick it up without knowing that this is not the treatment option. It is for prevention. I'm not talking about specific drops or anything. It is just in general the alternate therapy. So people pick up, instead of taking it as preventive therapy, they take it on as a specific treatment therapy, which is not right. And unfortunately, it is number one, it is hard to do research and prove we can't do randomized control trial for someone giving this particular diet and that, for example, ghee. We can't do randomized control trial giving the A2 ghee, one cohort, another cohort, just a normal ghee for 20, 30, 40 years and seeing the difference. It is just impossible. So some of the things which the other alternate therapy are going to be very, very difficult to prove from the research point of view. However, the allopathy academics and the researchers, they take those practices and that science in a different way. For example, my own institute is recognized type as a phase 1 studies. There are two or three in the whole UK. And my colleague in dermatology, I think just around the COVID time, we had our R&D had completed full research, and the drug was, I think it is in the market now for arthritis. That drug, we don't know the Ayurvedic name, but it is openly, they told me, and it is openly acknowledged when they were doing the research, that this is an Ayurveda molecular agent which we are researching and now going to use it for arthritis. But the Ayurveda original drug has disappeared, and we don't know which drug it was. So we will probably, what we will do is we will go down to the new drug, which is actually based on original research from Ayurveda. And the similar, only recently we had a meeting with R&D, and it is nice to know and that they are picking up some of these principles, because the new study they're trying to start is look at the molecules of the metals, because in Ayurveda the bhasma is used to treat, but it is a nanotechnology, so they have to the metal has to go through 100 cycles or 1,000 cycles of treatment, etc., which unfortunately that knowledge and that technology is not commonly used. But our now the allopathic academics and the pharmaceutical companies are picking up those things, but they will come out as allopathy drug. So it is just a little bit of an overview of what I personally see the interaction between this Ayurveda. It is there. People do, those who know, they do acknowledge, but they take it in a different way and do the research. Now, coming on to the prevention in the current era, in particular NHS, as Anukulji, you mentioned that I do all kidney day health checks, and we also have a charity, British Sanatan Doctors Forum, which is recently set up. Only last year we got the approval, and we have been doing community health checks in the community as well, in our own community, Sanatan community. So about 15 years ago, when the world started celebrating World Kidney Day every year, it is celebrated on second Thursday of March for nearly 16 years or so. And I was a consultant, so I picked it up. So initially we started checking blood pressure the first year, but then gradually I started checking all the basic risk factors which could cause chronic kidney disease, and also cardiovascular risk factors, for example, diabetes, high cholesterol, abnormal urine specimens. So this is something which we do in the community. We also check for atrial fibrillation and abnormal BMI. And recently we do cognitive impairment, cognitive tests as well. So if someone has got cognitive impairment in Ashton Temple. So what we have noticed, this is again, it is picking up the risk factors to prevent long-term complications like heart attack. And over the period of years, we've checked about the thousands and thousands of people. These are drop-in clinics, which I do free of charge, and we do in hospital setting, and also I do one in shopping mall as well in Liverpool. And it is interesting to see the first, second year we had all the executives coming down, and no one knew that they had a borderline high blood pressure, borderline high sugar. So it changed everybody's approach, and also medical rep as well, because I needed some sponsorship, because this is something which is not funded. I just do it as and when the money comes, and with the volunteers. And the medical reps also had an advantage, because they came and they got themselves checked as well. And over the period of years, I have checked myself as well when I was very young. And gradually I see my sugar level moving from 3.8 to 4.5, etc. So at the aging process also, we do not take it seriously because we don't have any symptoms. And in particular, our Sanatan community, what I've noticed is high blood pressure at a younger age is very, very common. And we picked up many young individuals with blood pressure of around 200 plus. And it was the Caucasian family who came down 2-3 years ago. And 3 of the family, my 2 young children and the mother, they all had very high blood pressure and significantly abnormal urine. So there was something significant going on. So this has been, and the feedback we always had was excellent. And recently we've analyzed full data for the 15 years review of our celebration and the health checkups. And it shows the blood pressure control. We haven't got the data on whether they are on hypertension, antihypertensive medications or diabetes medications. But this is just a snapshot review of all of these individuals who came in for the test at that particular time. But we would expect, including the staff, because we get staff coming like for MOT every year. They just come out and get themselves checked, and they come the following year, which is very popular. And looking at the data, it shows that even though people are on treatment or without treatment, figures are much higher about the prevalence of blood pressure. I'm not saying the control, the normal blood pressure values in the community from the group I have, those who attended the clinics. So that is a little bit worrying for Liverpool. So this is just one particular area I'm talking about. And I shared this with our trust in our annual members meeting and also in our yearly council meeting as well. And this will help us in the region to look at how this can be prevented and how we can pay the attention to improve the public health. This is public health. And the other side of this particular checkups is I usually invite our medical students and the sixth form students who come. I give them the induction and they come and join, and they enjoy the whole day process of learning about how to do the testing, how to communicate with the patients. So the way in which they also are prepared to work in the community and also for future NHS healthcare professionals, that helps as well, so that they are more aware. And they also can be inclined to join NHS, which is very important because we do need more staff in the NHS as well. We also do, as a charity, we have been doing the cancer awareness events as well, and they have been very successful because, again, our community and also general public, I think if anyone, those who are in the UK would have heard the speech, our King Charles speech, his own cancer, and the message he gave out, if the cancer is diagnosed early, it can be cured. And that is a very, very strong and positive message, which we have experienced last year since we became a charity and got a couple of grants funds from Answer Cancer UK. And we organized 3 events. One was the Havan event. The second was karaoke and music and sing-along event for our own community. And the third one was a formal speakers event. We covered 4 main cancers, including 3 cancers which have got NHS health screening, cancer screening program, like breast cancer, bowel cancer, and also we also included prostate cancer and the cervical cancer as well, because cervical smear is so many of general public. I'm not talking about our own community, but general public also. There is a lot of scare and anxiety before going for the test, which we all know if we have to go, we don't know what will be the outcome and what will be going through if it comes positive. And so this aspect of prevention, while the service, then health care service like NHS, which is free for everyone, the prevention is very, very important when there is screening facility available free of charge. But the awareness and information which is available, but it does not get transmitted to the general public. And our charity and our activities like World Kidney Day, cancer awareness events, etc., are very vital. And I can give you examples and examples and examples, but just I'll quote a couple of examples from the World Kidney Day, the health check event. The first or second year, we booked the shopping mall, and the security staff was helping us to distribute the leaflets. This is going back a few years ago now, before COVID. And he thought, let me come down. He was a young guy, about in his early 30s or something. And he came just for a casual checkup, and his blood pressure was 240 systolic. So the next year he came with me on BBC Merseyside, the radio program, because I would advertise the health check events every year on the radio. Our hospital communication officer will take me there. And he requested the public in Liverpool that you better go and get yourself checked, because I didn't know, and I would have ended up having brain hemorrhage, heart attack or something, or eyesight gone, all the complications. So that is one few patients we admitted as well. So these are the examples. And the cancer one is very important because so many couple of individuals also came, and that we wouldn't have gone, but now we are going. So yeah, this it is.
Thank you so much,
Thanks
Dr.
a lot,
Bhavna.
Bhavna. Thanks a lot, Dr. Bhavna. You can see how well the appropriate time intervention and assessment can simply take the person to a different level of care.
Yeah,
Absolutely. And
exactly.
I know how much she's working within the community to, mind you, it is just outside the scope of the NHS. So she's just working as a consultant, providing her services within the public, and without any cost to anybody. Of course, she's getting some grants, but the personal effort is unbelievable. Thank you,
Yeah.
Bhavna ji.
Thank you so much, Dr.
Thank you.
Bhavna. Thank you, Dr. Anukul. We now move to our next guest, Dr. Neha. Dr. Neha, you have been also working in the same field as a researcher, and you're a director of Arogyan as well. And now Dr. Bhavna had been talking about the same talks that we discuss about solutions on affordable basis, traditional medicine, as well as the conventional system of medicine, and how these things amalgamate. So what's your take for the NHS, as well as your opinion as a researcher in this field over the years? Over to you. Thank you.
Thank you. Thank you, Dr. Amrita, and wonderful meeting all of you again. Thank you for inviting. Yes, a lot of what I have heard today, everybody has covered all the different aspects of not only NHS, but the global health burden everywhere. And it's not differently what we are facing. It's everywhere where the global health crisis is facing in the healthcare system. But of course, NHS is what we are focusing as we are in England. There are, if broadly we talk about the burden on NHS, basically burden on healthcare system as a whole, we see the visible burdens. We see that long-term illnesses are the largest burden NHS is struggling with to manage, mental health crisis and aging population, multimorbidities. All this is very much visible that is burdening our healthcare system and people and professionals, everybody who are in this care. And of course, during the winter season or during the flu or during any kind of seasonal changes, we do see the acute system pressure, which is overcrowding our A&E and ambulance to the bed shortage, delayed discharge to recovery, rehab, everything. So this is all burdens, which is very well counted, coded, and also costed. So we know this is very much visible and we all are working toward to minimize. But there are, again, to look into the silent health burdens. And a lot of times, these are the burdens which are often unseen, underreported and sometimes not even reported, but we just normalized it to say, I mean, that's normal, that happens, is what's there to talk about. So it's rarely in form of the data, but that's actually very much a health burden. So if you talk about like early illnesses, preventative measures, we don't do that. So the early stages or subclinical stages, we miss that, but that is the highest burden. So chronic pain doesn't just happen chronic pain, but it's consistently in the early stages when patient recurrently calling GP, that is a burden on GP surgery. But then again, there is nothing visible. They can't do anything. Chronic fatigue, low-grade pain, gut issues, hormonal imbalances, sleep disorders. These are some of the subclinical early stages signs and symptoms which are very much silent burden. And people live with these symptoms for years before entering into clinical pathways of diagnostics to treatment. And again, we are very much on the treatment side rather than preventive or management, or especially self-management side of it. Then there is diagnostic threshold, mental emotional distress, if we talk about. So these are like brain gut axis, if we talk, or we talk about the trauma. So loneliness, grief, burnout, these emotional distress to the trauma which people suffer. And then in connection to all of this, when that triggers to the chronic illnesses or stress or exertion, that again takes a lot of time to develop into the clinical diagnosis, but that already is quite a high burden on a healthcare system, because that does not meet the criteria to be referred. But again, that is still a lot of time, the GP visits, the constant medication use, even the over-counter. And as Dr. Bhavna said, a lot of time people use to alternative which are not even yet proven effective, but they start taking it, and they sometimes start making a cocktail. So with the sleep medicine, they are also taking the herbal supplements. So these sorts of cocktail, when they are not knowing what that impact can make, that in terms sometimes is much more disastrous burden, and we don't even know that's happening to the patient because they don't declare this. Now, another silent burden which we often see recently, are we acknowledging it, is the culturally hidden burdens. And this is when minority, migrant, and diverse population come into. Now, somatizing distress, they have a very different expression of their own illnesses, and then their expectation to the healthcare system is also very different at times. And not to forget, of course, we all acknowledge stigma around all these chronic illnesses. Even at times with cancer, there is a huge stigma in our communities. When we talk about BME, Asian communities, we don't want to talk about cancer in the previous generation, or because then where are we passing on? So it's like a lot of stigma talking about these conditions as well, which we are a lot of information available out there. Then reliance on the self-care, self or medication, even the faith or informal support is much more higher than the clinical support at times. Because of the delays in NHS, we're not getting appointments there, we are not heard, we are not believed. So a lot of time people turn into all this informal support, which in return increases the burden, because then they take longer to go onto those routes, and then by the time it's already quite flared up. And on all of that, women, again, it's a complete different health burden when you talk about women's health, and especially menstrual disorder, menopause, perimenopause, all around. And very primarily, if we talk about our communities, Asian communities in general, that is again one of the largest stigma that we don't even talk about, go into silence, autoimmune pain condition. And recently, we also have been hearing a lot when I hear about the community conversations, caregiver burnouts. Now, a lot of these women are caregivers for elder parents, for in-laws, for the community, for the society, for their families in large. So the burnouts, and in return, again, that is expressed into different way of symptoms. These burdens are very fragmented complaints. They are not really a clinical diagnosis yet, but they started to build that pressure already on the system, because they are already on the calls, already on the GP surgery, waiting to be seen. test, diagnostics, everything is done, but nothing is clinically proven yet to be a condition, but they are suffering. Now, preventative care gaps is, of course, very much discussed here, so I won't take much. But then all these silent burdens actually escalate the chronic illnesses and crisis care, and that we know by the evidences already in hand. They not only increases the burden on healthcare system, but we know that they increase the medication dependency also. So, and then again, we talk so much about that widen, this whole scenario widens the health inequalities. So no matter how much we try hard to balance that inequality, but this is where it's unavoidable, because this is what actually making this gap much bigger. And it is creating unavoidable NHS demands. So all of that early community-led interventions, and primarily, I think a lot has been discussed, wrote it down as a pathways, wrote it down as a 10 years aim and agenda of NHS, but still there is a lot of missing gaps in the self-management part. I know preventative and early care awareness, patient education we covered, and that is important. But what missing link, what I also found we are not yet working a lot is self-management. And without this self-management approaches, none of these burdens can be minimized, because ultimately the caregiver and the physician, the caregiver, hospital has one part, but then major part after the treatment or after the protocol they have defined, the sole responsibility comes back to the patient, and that he mostly don't even recognize or realize that he has to do this. So if we talk about simply, we talk about diabetes so much, but the major part of the diabetes management is patient himself. He has to do it. He has to do the exercise, and he has to take care of his food. Only the medication doses is taken care by GP. But then before all of that, the main part of the doing is in his own sole responsibility. So how we share that responsibility, how we communicate to the patient. A lot of time, this communication itself is a burden, because patient thinks, he's not hearing me, he's not treating me, he's not doing enough. I mean, again, 5 minutes, what can I talk in 5 minutes? But he has heard you, he has seen your report. Now what he is telling you, that you take responsibility and take care of these avoidable measures and take care of these parameters on your own. But then the major part is overlooked, just to say that I wasn't given anything, I was just given an advice and to be seen in 3 months. So communication, again, here the culturally responsive approaches sometimes works, where of course GPs and the hospital may not have so much time, but that's where the social prescribing model comes into the picture. These models are already in place, and we don't have to do much, but we just have to utilize it to the wisely where it's needed. So where social prescribing is there, of course we can do self-management much better without utilizing much of the resources from NHS, but already in the community. There is so many community programs funded, supported by NHS or by the other council programs. But here we have fundings as well, community fundings. Now the gap between that, community funding says, this is NHS program, this is healthcare. We don't fund that. NHS says that we fund our programs, this is community. So that's where this is one program actually. We are talking about caring, taking burden from there to community, where it has to be, where self-management needs to be. So there has to be some little gaps where we all can bridge with the help of volunteers, with the help of organizations, with the experts, like a lot of doctors now coming to the communities and talking about awareness program. So this all can be bridged together, but the important part here is to understand not only visible or recognized derivals where we know that burdens are, but also where the burdens are building up and coming back to the system very fast, very quickly. So in my take on, if I have to say, of course, early preventative intervention to integrative models, all this is in place, but the silent burdens to look after and to approach them as a culturally responsive therapeutics, which we all are talking now to integrate as an integrative approaches. So, this is again not just one community we are talking. Culture is, if we talk about different colors, race, gender, every bringing to every environment, we're talking that is a different culture. So each person, precision medicine to narratives, what we were talking other day, all that lived experience to include and understand that how we take off that burden from not only from the system but the patient itself, and he understands that it is manageable on his. If we just communicate this one part clearly, that this is your care plan, you need to do this, and we will take care of this. And if you're doing anything else, you need to tell us. Then he takes the sole responsibility to understand that this is my approach. This is I'm going to do. But then he won't be desperate to look for alternative options randomly or without knowing or without talking to GP or consultant. So again, community embedded program plays an important role, which I am in last couple of years more active. But before that, when I was even on the community, before community, when it was in global campaigns too, on the conventional side of it or the pharmaceutical side of it, we saw the gaps from the other end. But when I see the gaps from this side, it's much more clear that we need to bridge this together. So I'll pause here and let the questions come. Sorry,
Thank you,
I
thank you,
think you're
Dr. Neha.
muted.
Thank you so much. Yeah, and you also brought up a very beautiful aspect of, you know, health coverages in terms of the communication skills of people as a physician, as well as affordable health solutions, and also talking about women in particular. I think in that audit case, health literacy plays a very important role, as well as the communication between the physicians and the public. And I also think public awareness programs also play a very important role. The better the public awareness programs in every country is, will give you a better insight in preventing a lot of people approaching the hospitals for small things, which I think they'll get a solution much earlier before they approach the hospital. As on, especially with the common kind of diseases and disorders people suffer from. And especially in terms of the lifestyle disorders and non-communicable, as well as communicable diseases, particularly, can be addressed in many different ways. A very big example can be just COVID as a prevention. COVID public awareness programs were done to reduce the health burdens in the hospitals. That was an emergency situation. Let's have a quick comment from Dr. Anupul G as well. Over to you. Thank you.
Thank you, Dr. Neha Sharma. It was a very nice presentation. One of the things I wanted to ask you was, how do you convert the people into persons who are responsible for their treatment? I mean, it is not easy to convert people because they have to. What I find is, in the few minutes, I come with a very awkward statement after many of my clinical assessment. I say, you have been with me for a few minutes over here, and I've told you a few things. How much do you think you'll take on, and how much will you change in these few minutes that will change your life completely? And often the answer, including for me, would be very little. And so I do take a time. I said, listen, I'm going to tell you the things, but I'm not going to make any change. I'm going to tell you what the issues are, and you have to understand it, and you have to take it on. And you are the only person who can take care of it. You can come to us any number of time you want. We will continue to do our business. That's all about it. But in reality, you are just going to be nobody else other than some other object in the conveyor belt. And that's no use for anybody. So I think you have to understand what the issues are. So majority of time I spend is to explain what's going on, both in terms of physiology, both in terms of what's going on in their lifetime, and also, very importantly, how it's impacting their life in one way or the other. Because in reality, most of the patients are very happy to take on the responsibility, but there are actually underlying issues within the family, community, and their work environment, which often prevents them from taking those actions. So I find it I find it much more difficult to go in behind the scene that what is it that's preventing. They will say, no, I've got two kids to, I've got to bring them out back from school at this age, at this time. I've got to take care of my mother. I've got to take care of the father. I've got to do this. And I've got to. And if you do not address those bits, that person does not have the right time to take care of themselves. I said, see, that is where you want to show your, if you want to prove that you love your family, take care of yourself. Otherwise, it doesn't work out. And I think that's true for everybody. And we were just talking about how we can prevent things from going wrong. I don't find any information about, for example, I was talking to Dr. Bhavnaji and she had given a fantastic talk on how question is, how do we prevent kidney diseases? How do we prevent this condition or that condition? And we are not aware of it. None of our normal education teaches us. And that is where things like what you call Ayurvedic systems really make a major difference. Because people will say, you've got to reduce your weight, so you've got to have salad. And everybody knows somebody likes salad, somebody doesn't like salad. Somebody says, if I take salad, I bloat. And somebody says, oh, I would enjoy salad any number of times. These change in characteristics of human beings is not known in our conventional medical system. That you have got, somebody has got Vata, Pitta, and all those kind of classifications. Those classification does not work out in the system. Therefore, there is a great need for us to really pick up the good things of other places and other systems and take them on and see how we can really make changes over there. Otherwise, we'll just be beating around the bush. And we are very reductionist in our medical system, that we only do this little bit and that's about it. But we totally neglect the other stuff as to what constitutes prevention. So I hope I've given some ideas which often influence the way I communicate with my patients. But I am very clear that, listen, I'm going to tell you a few things. You're going to listen to me very carefully and repeat what I've said to you. And you're going to tell me how much is affecting you. If it is not, then I've not made any change in your life. So medicines, and I'm a surgeon. So as a surgeon, I don't know medicine. I don't prescribe anything like that. I say, if it's a painkiller, go to your GP, he will give you better.
Yeah,
There is a
I agree.
beautiful, I mean, I'm sure Dr. Amrita would define that, but this patient physician communication, it is also defined in Ayurveda, right? Where it says a very important part that how these two communicate. So when I said about communication between the physician and the patient is important, that transfer, that from the physician, how you take the responsibility, that itself is a principle coming from Ayurveda itself. And of course, we need to take, this is precision medicine when we talk about individualization, when we talk about in the conventional terms, and of course, Ayurveda defines it into Vatpitka for individualization into different parameters. So we are already having some system, but again, to integrate how well we do it from the other conventional. When we talk about NHS, of course, the evidences come to the question. Because Ayurveda is not yet proven. So again, when we start integrating Ayurveda as it is, of course, that will be another gap into the NHS care in the system. But of course, we can integrate in different ways into the patient care. And if we all can do that within the NHS or outside NHS or around community, that is all we are looking at as a universal health coverage. I think that will be wonderful if that we unite on those parts together. But Dr. Amrita, I think it will be nice on that note to you take on how Ayurveda explained that communication between two.
Yeah, definitely. We also have Dr. Beatrice from France, who is also going to talk something on this. Well, Dr. Neha, thank you so much. That was a very beautiful conclusion on the way of the communication and the communication tips that traditional medicine has to give. And secondly, what Dr. Anukulji said and what you said are in line with a lot of things in connection to the family counseling, the caregiving, and a lot of aspects in terms of people as a patient, not as a burden, but as an opportunity to recover and to take these things away, not only from just one family member, but from the whole system around that decreases the burden overall on the health systems. Thank you so much for joining. Please stay around. We'll be having more chit chats with you. Let's move to France, where we have Dr. Beatrice waiting for us. Dr. Beatrice of Global Namaste, and a very good afternoon to you. It's lovely we are already heading towards the topic in relation to traditional medicine, but in France, what is the status of health problems related to different diseases? Over to you. Thank you.
Thank you for the invitation. I'm Ruta and Neil. So France is it's a huge topic actually, the healthcare system. It's very famous, I think, all around the world because we have a system that is refunding the consultation and the medicine. Most probably, most of you know, we have that, we call it social security. And it's a system which is refunding from the state at the state level. But unfortunately, it was so good because it was providing almost free healthcare for everybody who was staying in the country. It was so good that nowadays we have a huge debt on that. And they start actually stop refunding most of the medicine and also some of the consultation, because this is no more possible. Actually, the state can no more provide that. So we have that system, and then in parallel, we have another system with the insurance. So both are working together. So the insurance is covering the part which is remaining from the social security. But this is relevant only for the allopathic medicine and allopathic system. This is absolutely not relevant for the alternative approach like Ayurveda or naturopathy or even Chinese medicine, which are considered as illegal practice of medicine in France. So there is a huge, actually, there are two systems in parallel because you have people who believe in alternative system who will come, and then they know they are not going to get refund on anything because they are coming to this alternative system, which are so-called non-existing. Or you have another category of people who have no option and they have to go through allopathy because sometimes they cannot afford to pay for the fees. As we said, actually, burden is everywhere, in France as well. So when they cannot afford it, they just go to the allopathic doctor. They have no options. And even nowadays, we have noticed actually with some of my colleagues that the people delay the follow-up of the appointment. When you say to a patient that you have to come back in 3 months, the patient is coming back 6 months after or 9 months after. So it becomes a real issue because the diagnosis is totally missed. And whether you are in allopathic system, whether you are in alternative system, that will be the same. So this is another point which is really troublesome because when there is a diagnosis of cancer, for example, and the person is coming back 6 months after, what will happen? Actually, the cancer has really the time to grow, right? And to develop, for example. There is another thing also I wanted to mention to say how the burden is high on the French system is that I have also some patients nowadays, they are telling me, few of them, like they got operated and the surgeon is not doing the post-operative appointment. They just let them go. They just give the prescription and they have to manage it on their own. So it's also very complicated. So this is another thing. So to talk more about the system, I would say that the prevention exists in the cancer field, for example, but that will be on the allopathic side only. Nowhere in France you will see that there will be some prevention for the non-communicable disease like diabetes, for example, or whether you have to manage your food properly, things like that, or even for mental health care. Nowhere you see that, actually. There is absolutely no communication at the state level towards the people to prevent actually the occurrence of disease. And nowadays, even we don't even have enough allopathic doctors to take care of the people, and same with the hospitals. This is where we are, actually, at this stage. No one wants to go to the emergency in France because we know that we are not going to be taken care properly. So we have a huge challenge, actually. The system was very good at the beginning, but I guess it was not regulated properly and there was not enough prevention. and still there is not enough prevention. So the alternative approach are providing that, and unfortunately they are not how to say, they are not put forward enough. Actually, they're not trusted enough for that, and that's very sad, because the preventive approach of Ayurveda, for example, can do wonders, but for that it has to be communicated and it has to be propagated. And because it is not authorized in France, then they said no, it's just so this is not sustainable in the long run, I think. And even for the how you call after an operation, after a surgery or something, same way we can help with supplement and everything. But people actually will miss it because they don't know most of the time. They will just manage themselves. So there is a huge gap also there. So there was something in between.
That is.
So I think the so-called alternative approach has a huge actually role to play there. But there is also one thing we have to work with the insurance as well, because it is not refundable. The people, when they come to Ayurveda or when they come to naturopathy, most of the time, it's not refundable, neither by insurance, neither by the local system. And the problem is the people actually, they are used to this refundable system. And most of the time, I heard many times actually, they are telling, oh, yeah, this is very nice, this is working, but it is not refundable, we cannot afford it. So I think some middle path should be found. I don't have exactly the precise idea on the system because it's a huge system, unfortunately, but it must be found because the population is suffering from that. And I know there is a movement in France which started actually from one doctor who had been fired in the COVID time because he was not vaccinated. And he's trying actually to help out the people in villages in France to make them more autonomous with their health. And that would be a very good actually option, because if people can have all the preventive aspect and they can take care of the small, issue like cough and cold, things like that, or small allergies, if they can take care at home, then it's always better. It doesn't put so much burden neither on them, neither on the healthcare system. And then it makes them also more autonomous with their health. Because the problem of a refundable system or a free system, like what we have, is that the people are not autonomous and they are not ready to become self-aware of their health or to take any action. Because it's free. So why to do so? This is what I can observe from here. So it's a very good lesson because it's very interesting to see actually that there are very few people at the end who are really aware and who are really ready actually to take action on themselves and to change the things. This is what the French system has provoked, plus the fact that it has attracted so many people from everywhere. Because it's a fact also. That's what I wanted to convey about the healthcare coverage, because it's true that in France it's very specific, but it's not. I don't think it's very conducive as it is now. And now we are going towards more a system like in US, where everything will not be refunded, and it's a huge issue. And you can see that easily, actually, when you go to the dentist. I think you all have that in UK, in everywhere. Like you go to the dentist, the bill is really huge. There is no way it will be refunded. And this is putting burden, for example, on people and on families. This is an example. Or a surgery, which is not refundable also, because then you will have the clinic to pay, then you will have the surgery, and then you will have the care after that. Not everything is refundable after. And this is without talking the care also from the family, because some of the people from the family have to take care of the person who has been operated and all these things. This is also putting a burden, actually. hardly will we, how to say, we take all this into account, but this is how it is and how it is in France nowadays. So I think more awareness from the governments and from the authority would be good, to actually open the fields to the alternative ways to help with the prevention, because that way only it will be done. And this is very important.
Thank you, Dr. Beatrice. That is fantastic. I think uh, listening to you brings into light some of the very important issues. First of all, there's a good opportunity there as well. Now, here it is, your system over there in France does not allow you to use the alternative systems easily. It's question marked everywhere. This is a time to collect data. That how, by not doing this thing but doing another way of approaching, we are able to manage many of the conditions reasonably well. That can form what you call a body of data which can be of use for these alternative medicines in future. Number one. Number two is that, as I know France very well in terms of historical terms, revolutions, and cultural and other kind of so many things that has happened in France, the socialistic form, the rightist and leftist arguments, and a whole lot of stuff. I do a bit of reading in historical terms and how it affects the society. That's one of the reasons why culture has a huge impact on how you treat yourself, how you treat your community, how you sort of remain healthy and everything. And that's one of the reasons why we are trying to have a conference a year after next to see where we can get all these things together, that your culture, your traditions, your economics, your politics, they all influence the way we live. And you said some very, very important words. Your independence. It's interesting how our ability to make the choices that are good for us are often taken away from us. For example, if I want to go to an alternative medicine expert, if I feel, well, if I am not feeling well, and if I feel that I want to go to a priest and he gives me a blessing that God is going to do you all good, and I feel good about it, why should I be deprived of doing that? I should go. Somebody, if I feel, oh, it's a placebo effect, I don't care whether it's placebo or not effect. I feel good. That's all about that matters. And if I'm not able to do that, no matter what it is, an alternative system or everything, then you're taking away the independence of the person. To that extent, I believe that is something that we have to look into very carefully. So it's a time and opportunity for us to collect the kind of data that you are going through. Alternative medicines. Now you've got the data that this thing was helpful, and that might helpful be for us all in future, and how we can change our politics, economics altogether, and see them in a whole basket rather than trying to say, no, you're not going to do that and lose your independence. And I'm going to say that in terms of working through the insurance companies, there's a lot of interesting data from there. But many of the insurance companies would like to make profit, but there are many other issues also behind it. Because I've worked closely with insurances, there's lots of interesting things in it. But there's a lot of good opportunities, by the way. So it's a bad thing, but a lot of opportunities as well.
Thank you, Anupul. We'll keep in touch with Beatrice. Bonsoir, Beatrice.
Good evening.
Lovely to have your contribution. And as Anupul said, that here is an opportunity to exchange ideas, again, integrating health as well, which is very important. Stay around. Let's go to USA, Anupul, where our senior host, our contributor, and a regular producer at Healing Our Earth, Sharon Rose, the bubbly Sharon Rose, is waiting over here. Sharon, a global namaste to you, and how are you?
Global namaste to all my beloved friends out there. I am in, what can I say, bliss. We had this really, really beautiful sitar concert here last night with BJ Shrestha. Talk about healing music. Woof. And also kirtan, and I will be showing, bringing them in next week for our great celebration of the holidays and showing you some video of this beautiful, beautiful music.
Beautiful. And for health, music is a superb medicine. So
Oh,
I think
it is the best. I've been looking into, well, you'll meet in a bit, you'll meet my co-producer, Michael Verdick, and we're working on a meditation album right now, and we're really looking into the solfeggio frequencies for healing. And so we'll talk a little bit about that. But
that's
first,
great. That's
yes.
brilliant, Sharon. And before we meet your co-producer friend, who will be coming in shortly, let's actually go to Paras, who
Yes.
again is your friend and she's here. So let's welcome her and actually enjoy because she's also integrating sound. And
Oh,
there is a
yes. Oh,
proof that
yes.
sound is very useful.
But
So let's go to Paras here, and she's here. And good evening, or maybe good noon or good morning in America.
Morning, yes, yes. Now, what I'm going to talk about is a lot different because it falls under alternatives, okay? So, and you should know that my background is not as a doctor or a scientist, but more as an artist and a researcher.
I want to
So,
introduce you.
oh, okay.
Well, the first thing you all should know is that because you've met Peter Wayne, you've met a lot of the people that are important, and doing great research in the Qigong world on the show. And Paris is now the chairman of the board of the National Qigong Association. And we are thrilled because her background just includes so many diverse, wonderful experiences from working with neurofeedback, from making animations, from, it's music and art and all the things that we love here on this show. And I'm very thrilled for what she's going to talk to us about today because it's very unique. And many years ago, I heard about this work. And so I'm excited for her to tell us about it.
All right. Well, I wanted to start by talking a bit about a mentor of mine, Dr. John C. Lilly. I met John at an environmental conference in Sacramento, California, and he was one of the guest speakers. I was excited because when he introduced himself, he walked in a very dignified way onto the stage and he bowed to the audience. And then he said, I would like to introduce myself to members of the human species. Now, this excited me because in saying that, he was acknowledging that we are not the only species. The humans are not the only species. John actually started the Human Dolphin Foundation in California, and I was part of that foundation when I was living there in California. During that time, we had two conferences that took place in Cancun at the Isla de Mujeres, a little island where there was a dolphin center there. And as part of the conference experience, we each got to swim in the water with the dolphins, just us, just one at a time with the dolphins. And I have to say that that experience changed my life because what I experienced was when the dolphin communicates with you through its sonar, through an echolocation system, and that communication is at frequencies that are well over 100 hertz, closer to 150 and even 200 hertz. And I think that frequency, what I experience that I describe now, is that being sonared, biologically sonared by a dolphin, has the effect of vibrating the neurons in the brain. There's liquid in the center of the neurons, and the vibrations create a resonance that then creates coherence throughout the brain. And when we have, the more coherence we have in the brain, then the more coherence we have in our full body. And I think that this is a healing effect. So that was my first experience with being in the water with dolphins, and I had 2 opportunities to do that. I then proceeded to make sure that my daughter as a child had several opportunities to swim in the water with dolphins. So since the dolphins can vibrate those neurons, I think that they can reprogram us, transform any negative energy or thoughts or conditions in the body, to transition and convert those to positive forces in the body. The subject of the conference was really about dolphin healing, and there are dolphin centers where the dolphins, because of their unique sonar ability, they're able to detect cancerous tumors in the bodies. They're able to detect those before the human is even aware of it. And then at these centers, the repeated time in the water with the dolphin, as the dolphin would continue to focus its sonar beam onto the tumor, that there had a fair amount, I'm sorry, I don't have statistics, but a fair amount of decrease in the tumor. So it was determined that the dolphins are effective in providing healing capability to humans. So these experiences led me to have an extreme interest in sound, not just hearing it, but understanding the frequency and the intensity of sound waveforms, and made me start to think about how we can accomplish with our sound what the dolphins do naturally, which of course we can't really do except maybe with the help of technology, which is my other interest. But I started working with a BCI, a brain-computer interface to the computer, because of this interest in frequency and intensity and the brain, and how altering the vibrations in the neurons affect the body. And I started doing a lot of before and after different experiences of testing, before and after meditation, before and after yoga, before and after Tai Chi. And eventually I came to Qigong, and the realization is that the serious study of Qigong is the study of the body as an electrical system. And the practice of Qigong has to do with activating energy that is in the body, that is part of this electrical system. And we all have that energy, but it can become stagnant. And it's important that we do things to stimulate and keep active that energy. And that's what the Qigong movements, the sequence that I'm particularly fond of is organ cleansing, because there's a move with organ cleansing Qigong to stimulate the energy in each of the organs in the body, including the brain, And in doing so, balancing rhythms of the heart and creating optimal heart coherence. So that's how I got to Qigong. Studying the neurofeedback before and after, I realized that low frequency, consistent, controlled intensity of sound waveforms creates more coherence. So I started working with taking the neurofeedback data and using the brain-computer interface, bringing the data into the computer and assigning the data. Well, first there's a conversion process to MIDI data, and then assigning that data to digital instruments or computer graphic objects. And what I found was that when I am in a calm meditative state, the sound is very ambient and very pleasing. And the animation of objects is very smooth and controlled. But if I am in an agitated state and am using the same system, then the sound is chaotic all over the place. You don't even want to hear it. And the animation is rough and not at all something that you want to watch. So I feel that that working, we have that ability to self-regulate our own bodies. And as we were hearing from all the wonderful talks before me, the attention to alternatives or the support, the financial support for alternatives just isn't there these days with our medical health systems. And so I think we have to bring it on, take it on ourselves, and learn more about what happens in the brain, what happens in the organs of the body. If we think of the body as the electrical system, each organ has a biofield of energy around it. And then the whole body is a parent system to the organs, the individual organs. So how stimulated and energized and rejuvenated each organ is, that influences how powerful the energy field, the biofield around our whole body is. So and that's why the organ cleansing Qigong is of such interest to me, because working individually on each organ, that affects the overall body biofield, which is just fascinating to me. And I think it's all leading towards a future where energy healing will become more prominent in our culture, and a combination of energy healing with allopathic medicine will be embraced and necessary for us to proceed into the future. Back to the dolphins, they have a melon, and the melon actually acts as a lens that focuses their sonar, and they can like direct this, and they can send that out, and when it hits an object or it reaches an object, then that object sends back something like an echo, which is why they call it echolocation. And that brings information to them, and they are so sophisticated. Their brains are huge, much larger than our brains, and that they receive information, and the detail of the information that they get from that their communication systems is pretty phenomenal. If only humans could have that capability. So that's kind of where I think I should probably stop now and see if there are questions.
Well, it's interesting, what you're saying. It seems that we were discussing the exoteric the other day as opposed to the esoteric. And it seems like the medical system is so concerned with the exoteric, with, relieving symptoms,
Yes.
rather than really the deep, all the aspects of a human being, all the systems, the emotions, the thoughts, and all the reasons why, dis-ease has appeared in the first place.
Yes, and another influence on my life, major influence, was my father, who, among other things, he was a hypnotist. And from the age of 5 to 14, he worked with me using hypnosis. And now I think he was programming me for future goals. And he, unfortunately, he like suddenly died overnight when I was 14, unexpected, no symptoms, but a massive heart attack. And so, of course, losing him like that made him even more important to me. But he always talked about the brain and the future of medicine, being based on the brain and the importance of the brain in the whole body. And that also influenced me to start working with the brain-computer interface. I started working with two Japanese developers in 1992, and I was exhibiting at LA Convention Center, and they had an exhibit next to us, and it was the brain interface, and I could see brain waves on the screen, first time ever, and it's like, oh my gosh, I didn't even have a computer then. I bought the software, and then I went out to find a computer to play it with. That really has a lot to do with my father's influence, because it was like, I don't know how this is going to help, but this is going to help me understand what he was trying to say to me. And perhaps hypnosis is the closest kind of activity that we can develop, the closest to biological sonar. I hadn't thought of that before, but
Namaste, Anukul.
Yes. Thank you.
It's
I just
always
it is interesting to note, because it is quite surprising that our link with the animals are always very, very profound. We don't seem to know it. We don't seem to understand it or appreciate it. In reality, as we are all vibrations. We are all energy. Every
Yeah.
cell in our body is a vibration. And it's only when the vibrations are synchronized that we live satisfactorily. And we have to. So same thing happens. We have got quite a few of our patients who have got specific dogs or cats who can detect something is not right. A dog
Yeah.
will say, "There's a time to take your medicine." It will guide you. It can smell something is not. In fact, many patients with psychiatric conditions, the dog will tell you ahead of time that your behavior has become different. You better take your medicine. It will start indicating that you're going to take your medicines. So it's not there only with dogs, it's also with cats. They can
Yeah.
also recognize a lot of psychological things there as well. Plus, rats, by the way, rats are very good in detecting tuberculosis.
Wow.
And in Africa, they are, yeah, tuberculosis, they tend to figure out which kind of sputum when people spit there, and then they get to know that this is tuberculosis. I don't know exactly how they react, but they are known to detect tuberculosis. But also underground mines to prevent people from tripping on them. they often do things around the mines, and they can detect where the mines are if they're kept in those places. And same thing with pigeons, apparently. Pigeons also have a tendency to detect cancer, but apparently by the structure in which the cells are laid around in the cancer cells. So I don't exactly know how they have done it, but I know they are there. Horses are very good at detecting your psychological factors, and they're also very good in managing back pain, by the way. Many of the patients, so they are very good connect with the human beings. And there are badgers and quite a few other animals. I've forgotten all of them, but they all are linked to human body one way or the other. Whales, no, what do you call this? You're talking of dolphins. Fantastic. They invariably have lots of synchronized activities with humans. So, I mean, we don't take that very well. One animal which people don't discuss much about, and I get absolutely what do you call shocked by their understanding about human life, are cows in India.
Oh.
They will cry way beyond time before things go wrong at home, before people fall sick. They have tears coming out from their eyes. They're far away from you. They're, in the sense, they're in the cow shed. But then you'll get to know something is going to go wrong. They tell you ahead of time. They're very moron. They're very quiet. They'll sit quietly, and they will get to know that something is not right. If somebody is going to pass away at home, they will tell you a day before time, or a few days before time. And sometimes they are unusually connected to the human beings and the feelings and emotions around the house. And I've got numerous stories around the house how a given cow, I mean, we had lots of cows in our house, how a given cow will tell ahead of time that this is going to happen, will be showing its pleasure or displeasure or generally keeping quiet, but it will tell you exactly what's going to happen. And the person who's been taking care of the cows will come and say, this cow is not particularly well, or something is not right. They'll come and say something is not okay at home, watch out. It's just
Well,
amazing.
I think that some of what you're talking about, and some of what's so wonderful about our animal friends, is that they are not intellectual or academic. They are intuitive, and they operate at the intuitive level. And certainly humans can too, but our cultures have phased that out so much. There's so much noise around us that getting back to our intuitive minds is it takes an effort, which things like qigong and meditation help us do that. But yes, animals have that naturally.
Absolutely.
It's a beautiful thing.
Thank you. Thank you, Pars.
Yes, thank you for having me on the show.
Well, now, and I'm glad you're here, Paris, because I really want you to meet Michael. Um, I'm very pleased to introduce Michael Verdick. The people on the show know I've been working on music for quite a while, and you've met Bing Chen. You all met her, the great Erhu virtuoso from Chinese, who has been instrumental, literally, in our work. And let me introduce Michael. We've been, you all know that of my background in India with my Guruji Siddhara Devi, etc., and that Indian music and Indian dance and Indian philosophy play this like extremely deep role in all my work. And the healing power of Indian classical music is profound. Just the science of it, the ragas, so sophisticated. Different ragas have different effects, different times of day associated with different deities. It's so exquisite. It's such an exquisite system that it has pervaded everything I do. But let me introduce Michael. Michael Verdick is a 30-year, probably more than that now, veteran of the entertainment industry with gold, platinum, diamond, and Grammy Awards, and has contributed to the sales of over 63 million, records alone. And He's done all kinds. He's a recording, he's a producer, mixing and mastering engineer, music editor. He's had his own companies. He's worked with artists such as Madonna, the Eagles, John Lennon, the Jets, et cetera, et cetera. He's worked on movies, and he's working with me.
Good morning. It's great to be with you. I just wanted to mention, part of what Sharon and I have been doing over the last few years is exploring, discovering different types of music and how they mix together. For me, this is an outcome of probably my youth growing up with the Beatles, and of course living near the Sunset Strip in the 60s, where music cultures had no boundaries like they don't. I mean, today, unfortunately, we have a lot of things siphoned off by marketing. And one of the things that I used to do when I owned a studio is I would wire the studio with special cable to get a different sound. In those days, in the pop culture, we would say, "Oh, make a new noise." And I also modified 2 recording consoles, a Trident TSM and a Neve 8108. And it would take months to redo the electronics, all in discovery of new sounds. We would change the capsules in microphones to get a different sound. So this discovery process is part of what the music, and there's a song called The Tao that I don't know if they've heard The Tao yet, but
No, we're going to play the trailer today.
Excellent. And of course the soundtrack album to Quantum Chi, the film, it's a combination of mixing of different sounds and cultures together. And I think that this discovery process is something that interests me greatly. And I also wanted to mention, in my background, in addition to reaching people with pop music, which has been a blessing, I've been able to also work with a company called The Wild Divine Healing Rhythms, where we did biofeedback video games. So you would navigate through the game by raising and lowering your heart rate, and then an extension of that, not to make small of that, was we were getting into neurofeedback, and there was a wonderful woman named Liana from Inner Key, and she was one of the mentors of the game, along with Deepak Chopra and Nguyen Kachong and other people. And the thing that struck me when I did neurofeedback is how difficult it was if you tried hard to get anything to work. The harder you tried, the worse it got. It's like meditation. If you're focusing on it, you're not doing it right. And so music resonates with people in ways that other things sometimes can't. Music can resonate with somebody that would, if you said to them, "I want you to meditate," they'd say, "Oh, I don't do that." If you said, I want you to think about these thoughts or whatever, "Oh, I don't want to do that." Music takes us to places that we can't go otherwise. So, not to get too lengthy into this, but basically, Sharon and I have been mixing different cultures together in addition to sounds, and I think the effect is resonating with people in a way that you hope. We're pretty jaded in our stuff in that we've worked on things for months, sometimes years. So if we can still feel it, we feel like other people might too. And that reaching out to people where, and getting multitudes of, maybe hundreds of thousands of people to resonate with it is really important. It's a first step maybe for some of them to get to where the deeper stuff is. I don't expect people to gravitate towards biofeedback and neurofeedback, but if I can resonate them with certain tones, that we do inside the music, they will feel things like that, and maybe they'll go deeper. Anyway, I just wanted to blurt out that, Sharon, for an opener.
Yeah. So I'm going to show you in a bit the trailer from this music video, The Tao, that's part of the Quantum Chi movie. And I do have to say that now it's won 7 awards in film festivals throughout the world. And so we're very pleased at how it is resonating. at these film festivals. Because it's very, the piece is very esoteric because it also has a, the words are from our friend John Milton, who's been on the show many times. I asked him to do a reinterpretation of chapter 16 of the Tao Te Ching about the way of nature. And so it's very deep, contemplative words together with what we did. I started with Rag Bhopali, which is dedicated to Saraswati. You know, it's very meditative, and then I gave to the we put on tanpura. We didn't have a swar mandal, which I wanted, but we used an auto harp tuned appropriately, and then we had Jebing come on, and there's something about this. Everyone, well, maybe I shouldn't say, but I played it for people of all cultures and ages, and the first thing they all say, "Oh, it's so relaxing." And you know, sound. You all know, you've been from India, and know Indian culture, and know how powerful the healing aspect of sound can be on humanity. And this is what we're working for. You know, I always thought of music and dance as a universal language. And in this work, we really do our best to bring the world together through sound. What we really need, and working on a level that doesn't really have to do with taking pills and all of those things. So let's talk a little about how we do it, and then how we work, because it's a very interesting way we work. Michael, when the pandemic hit, when I actually met all of you, he found an application called SessionWire, in which we could virtually be together, as though we're there in the studio together. I can see his computer. I can, everything on that I see every track. I can hear every track. I can see everything he's doing, and we can discuss everything. And then we can be virtually in the studio while people are recording with them, see them and direct them all over the world. So our dear friend Wai Ching, Amalia Wai Ching, you'll hear her voice in this little excerpt. She's the narrator. And she was in Malaysia. I was here on the mountain in Crestone, and Michael is outside of LA. And so this technology has been a great boon to our work. And I've suggested it to many musicians, etc., and they're very excited about.
It makes you feel as though you're in the same room. I really don't feel the separation from Sharon when we work together. It's as though she's right here. The other thing is that we're not going to let you go away with just that today. We also developed a technique where, like the pandemic was the mother of necessity, we wanted to work with Jebing Chen, and we couldn't find a studio to hook up with her with SessionWire. So I devised a method where I sent her equipment, light equipment, a microphone and a preamp, and then I put software on her computer where I could remotely control stuff. So I put the recording software on her computer called Pro Tools, and while we were doing our SessionWire thing, as we normally do, then I would work her computer and she would perform. And I would change the tracks, and I would download and upload files and so on. So we've really taken remote recording to a new level, I think, and because of it, we can create things that we couldn't create before. And I wanted to mention just one other thing, is that I don't expect everybody to meditate. I don't expect everybody to understand certain things that maybe we all know about music and about vibrations and tones and frequencies. But I do know what it feels like. And if I can get that feeling to somebody else, then maybe, just maybe, they're going to go a little deeper, or they'll feel that same resonance. I wanted to mention one other thing, is that I'm also a second-degree Reiki master. And so energy working, vibrations, sounds, these are really important to me because I resonate with them. And I think, you know, if you look at the general way that music is projected, not all music projects something positive, but it can project something very positive. Anyway, back to Sharon.
Before I play this for you, we had such a beautiful response that we've decided to turn the Tao into an hour-long meditative musical experience. And we're always, well, you know me, I'm always looking to see what we can do to help people heal. And so we've been now looking at these, if you have heard of them, the solfeggio frequencies. And they're frequencies that align with the chakras and align with different healing qualities. And you'll hear a little bit of this Tao, and now there's a frequency, so I don't know if you know that at a certain point, like Gregorian chant was in this frequency, 432 hertz. That was, and then I was told yesterday that the sitar was in 528. So they have different, also as they rise, they have different effects on the chakras. I think there's something like a 938 or something that's supposed to open your third eye, etc.
And for those of you wanting to experiment, you can experiment with us, because our hope is the Tao meditation piece is tuned to 440, A440. But we hope to also offer a 432 tuning version of it. Only we're not going to use electronics to do it, because they generally produce artifacts that could be very disruptive to a meditation or even a feeling of something. So I'm going to attempt to use an analog tape machine and VSO it down, which will also, in addition to maintaining the complex harmonies, because when you have a complex sound like a piano or an auto harp and you electronically try and alter it, it can produce a lot of artifacts. The analog should maintain those frequencies, those harmonies, and those harmonics, and it will also slow it down just a little bit, which should be an interesting experience, I think, for all of us. Anyway,
I think what we should do is, have the Healing Our Earth community here as when we do the 432, send it to them and have them listen to the two different ones and get their response.
You take the test.
Yeah.
440 or 432? What shall it be?
So I'm going to share this this little excerpt. You'll see our dear friend, you'll see Jay Bing Chen, and you'll see our dear friend Amalia Wai Ching in this. Okay. Where is it? Oh, I have it here.
The way of nature is unchanging. Without certainty in the way, the foundation is obscure. Realizing confidence in the way primordial source awareness opens. This pristine, clear openness reveals the heart of compassion, a compassionate heart and flowing one with true nature supports true leadership. Cultivating true leadership, one realizes the sacred way, embodying the sacred way. One flows with the Tao.
I thought that excerpt would be very timely, you know. Could we really have true leadership, you know, coming from the heart? You know, that's what our world needs.
We can.
I believe we can. I mean, we're in a very transformative time. As last week we had an interview about the shift in the yugas and all the light coming in, and at the same time, the Kali Yuga people are like grasping, holding on, and we on the show are doing everything to bring beauty and light and all of the amazing teachings that humanity we've had throughout the centuries to bring happiness and health to people. And I just really feel that I think the pandemic and all the problems with it caused a lot of people to wake up and understand and experience healing modalities such as Ayurveda and traditional Chinese medicine, and that they are starting more to be integrated into our system. I read that Kennedy and the people, Jay Bhattacharya and those people, are really starting to look at, you know, finding ways that people could be reimbursed for alternative health, and that would be an extraordinary thing. I mean, healthcare for all. Yeah, let's start with, you know, taking care of yourself, eating well, you know, all of the different things.
Sharon, I wanted to make a comment about your sitar concert. I, at one point, did a little video documentary with Ravi Shankar, and somebody asked during the session, somebody asked him, "Why did you choose music as your medium to work with?" And he paused and he looked up and pointed up and said, "It's the most direct connection." I thought that was so beautiful.
Oh, it's a treasure. I do want to mention to you all that, you know, right now in Mumbai, I think today, tomorrow, this week, they're doing a tribute to Zakir Hussain. I spoke with his wife, who's my gurubai, last week. And so John McLaughlin, a lot of, you know, all of these people who were very close with him are there. So if you're in Mumbai, you might want to check it out. Also, the Tao film is being shown at the 14th Mumbai Short Film Festival. I think it's today or in the middle of the night. So Michael and I are very pleased that this music that we are creating has been received in such a way, and we are just going to be continuing on this path. And I really want to you'll meet BJ next week, but I want to bring him into our music, because when he's not only a amazing sitar player, but he's also an amazing tabla player as well. And so I just, you know, what can I say? I was in a bliss state last night. Okay, future online episodes. Next week, Sunday, 21st December. Festive season, fun, laughter, sing along. This is always a great episode. We have so much fun. People come and contribute Bollywood and devotional and all kinds of things. And so please join us next week for this wonderful time. And we wish you all the happiest festive season. We'll be back on the 4th of January, 2026. And it's going to be an amazing year from what I hear. The energy is going to shift, and we're going to have a much healthier, happier year, especially, let's see, bringing forth all these beautiful teachings and embodying these teachings, and really all of us becoming the, how do I say this, to be so deep in these teachings ourselves that we emanate and people are magnetized and they look at us and say, wow, this person is so healthy, they seem to be happy, and I would like to be like that. And then they say to us, oh, how can, what are you doing? How can I, be healthier? So, and then Happy New Year. On the 4th of January, we're going to have another celebratory show, Bhakti Yoga, bhajans, chanting, kirtans, mantra, and spirituality. So please join us through the year. We have all these wonderful shows on healing from all different modalities throughout the world, and vegetarian cooking, and all the big holidays, Diwali, and all of these holidays, and environmental shows, and so much more.
Thank you, Sharon, for bringing wonderful guests every week for so many years now, including Paras, who shared her experience over there. Paras, is that real snow, or are we looking at virtual backdrop?
There is snow today, but it's a picture from the snow here.
Amazing. And it's also very, very cold in India. Temperature has dropped to
It is?
3 degrees.
Wow.
It's so cold up there, and it's cold here in London. And Michael, very well done. I loved your
Thank you.
combination that you've created with Sharon. I'm going to bring Amrita back here. You can see she's obviously covering her head. It's so cold. She's in India, and the temperature where she is right now is nearly 3 degrees, which is even cold for us in London.
Well, I'm looking out my window here in Montrose, California, and it was 78 degrees yesterday. No snow yet.
I love California, and I love hearing about what you're doing with music and sound. It's so exciting.
Yes, sound and music is so healing. Even when the babies are, when the mother is pregnant, sometimes they use sound therapy, and it's soothing. And as far as you experience that with dolphins, for example.
Yes.
And then you wonder that, is the human form the most intellectual, or is it because we think we can communicate that we are? So out there, animal kingdom has got so much amazing way of communicating with life, and they don't even have doctors and surgery, they survive as long as they can, and off they go. It's good. Amrita, thank you for joining us back again. You are in a very cold, chilly part of India at the moment. I hope you heard the music. Amrita, can you hear me?
Yeah, I can hear you, Nil Kumar. Thank you so much.
But I can tell only one thing, that when I go to India, many of my friends say, oh, it's very cold over there, so you must not be feeling cold over here. I said, hang on, it is the other way around. Because quite unlike here, I mean, over here in UK, all the houses are nicely warmed up, so you don't feel the cold. But when you go in India, really, it's there all the time. And you don't have some normal heating system. So it is much colder there, let me tell that to you. It is certainly much colder there.
It's amazing. Neetu, you wanted to make a comment? Neetu was an earlier contributor.
I could not wait to thank Sharon, Paris, and Michael for beautiful music. I'm into holistic approach to health and well-being, and I highly recommend music therapy for healing for sure. Yeah, and I wanted to ask, is there any platform where I can access this music, please, and promote it to my clients?
Oh, well, thank you so much. It's coming.
It is. Okay. I look forward to it.
Pray for me this next week. I'm putting the film in for distribution. And
Fantastic.
as soon as I have that, and we're sending them we're starting to, well, soon, like in the next 2 weeks, we'll be sending the music out to distributors as well. And
Fantastic.
so I'll keep you all informed.
Thank you.
And yeah, once we know it's out in the world, then Neil and I have been planning to do a whole show on Qigong, bring all of these. And Paris, I'd love for you to come back and bring people from the film and talk about the healing power of Qigong.
Yeah, in fact, Sharul, I was also thinking to talk about music and healing, and let's produce one complete episode on music and healing.
Yes.
That would be
Yeah.
fantastic.
That will
I
be
That would be
fabulous,
amazing.
actually.
Yeah. And also Michael
Next
mentioned
year.
about Reiki. So again, reflexology, Reiki, hypnotherapy, I promote
Yeah.
all of these because I believe one size doesn't fit all. We don't know what people might find useful for their health and well-being.
Absolutely.
Yes. So
I
I
think-
offer them everything and let them make their informed choice or decision. So
I think
You are a,
you know,
you are a part of the Healing Our Earth family. You are in touch with Amrita via WhatsApp. She will connect you with Sharon.
great.
You can
Thank
also invite Sharon onto your platform online.
you. Mhm.
She will with pleasure come and also give a free lectures or contribution, because at Healing Our Earth, everybody contributes freely to create better, harmonious, loving community. So it'll be nice. And as for music from Michael and Sharon, you heard Michael's repertoire. He has worked with some well-known artists, and with the experience of going well over 35 years, he's used to the old system, and now technologically is advanced as well. So he's a true example of a hybrid person when it comes to mastering music. It's a special job.
I also think it's really important that knowing things about energy and knowing feelings about it, when you can replicate that inside your music, it gives people a chance to go there with you without being intellectual about it. The other thing I wanted to mention just in closing is that Sharon and I, we have always big dreams. And so one of our dreams is I mix also in a format called Atmos. Atmos is multi-speakers all around the room. So maybe you have 4 speakers on the top, you have 7 surrounding you, and you have a subwoofer. And so the idea is to take the music and make it into a multimedia event where the person can not only hear the music, but they hear it in a way that is truly uplifting when you hear multi-channel. And even in the commercial world, they have binaural music, meaning it's mixed in Atmos, but you hear it in a headphone and it just sounds a little different. These are all ways of communicating, because that's what music is. Music is communication, just like songs are. And so reaching people is really key.
I have one question for Michael. I go to USA almost every year, and one of the places that I enjoy going to is Albuquerque, and got a lot of Native American music. So I collect a lot of this Native American CDs, and they are amazingly, in tune with Mother Nature. So I wondered I don't understand music, but I just enjoy it. So maybe you can tell me a little bit about the Native American music.
Well, I don't profess to be an expert in it. There was a tribe that I was interested in up in Yosemite for a while, but they are very protective of their music in the sense that they feel sometimes that the music is a representation. It's like a reflection of their soul. So, but a lot of music today, and I don't know which ones you were listening to, sometimes it becomes a hybrid of sort of a pop music influenced by. Sometimes it's actual recordings of them chanting and dancing and doing things. But I think, you know, it's really about resonance. So if something resonates with you, you go with it.
Absolutely.
And you know, we don't analyze. We just say, yeah, that feels good.
Yeah.
And I think that, you know, with a lot of the things that are going on today, see, I remember when music was more universal, when people didn't have labels, when I was a kid, I would go to see Bowie. I would go to see a country pop band. There would be an Irish folk band opening. I saw Ravi Shankar play at the Hollywood Bowl. You know, there were no boundaries. And I think that one of the things that Sharon and I are attempting to reach out to people with this music is to start breaking down those boundaries and letting people, because it reflects how we feel about each other too.
That's right.
And
I
just want to.
I must say that, you know, I have friends, you know, American friends, who have trained deeply in other cultures, but they complain that they don't get work because they're not of that culture. But I really want to express my gratitude to everyone in India, because I have never felt that. I have only felt totally welcome and appreciated, and I'm so grateful to you all.
So Sharon, as agreed, let's bring a sound and a healing episode. A different international. Well, we also do that in the Bhakti Yoga episode on 4th of January. We bring different people from different parts. We get Armando from Australia, who is an Aborigine, who brings his way of chanting. We go to India, we go to Africa. Maybe early part of January we bring that. Amrita, you and Sharon decide, you got the diary and some free dates. And meanwhile, Sharon, you can end up right now with Gayatri Mantra in your style. And then we will say good evening, good afternoon, good morning, and off we go to our.
I did want to say, though, in response to Michael's big dream, another of my mentors said, if you don't have a vision for the future, you will not have a future.
Beautiful.
Well said.
I do. Since you brought this up again, my vision is we've met my friend Asha, who created Pacific Domes, and they make these multimedia domes. So you can do this surround sound, you can have projections, and so we have this big project we're working on called The Nectar of Bliss, a musical odyssey into the many faces of the goddess. And so, of course, I've sung parts of the Sri Suktam and Lakshmi, and then Egyptian and Tibetan and Mary and all of that. And but I do want to say, and I've told you this, that my deep immersion in Indian music influences everything I do. So I was telling BJ last night, I'm going to play some. I said, you're going to hear, I'm happy I'm playing for you, because you'll hear, I'm in Egypt, but you're hearing my tihais, right? So, yeah, you know, together we can build a really beautiful future for our children and our children's children, and in alignment with the earth and with each other from our hearts. So
I also wanted to mention.
Heal the earth for creating a better communities. Okay, Sharon.
Michael?
Gayatri Mantra, and we can finish,
Yeah.
please.
Well, Michael wants to say something, and then I'll.
Oh, one last little technical tidbit or nugget. When you're mixing in surround sound and you're creating environments that don't really exist in normal reality. And so the idea is you're exploring to see what happens if this was here, that was there. In surround sound, some people would say, okay, well, I want to sound like I'm in the middle of the orchestra, or I'm on the sides of the orchestra, I'm in front of the orchestra, or the orchestra is partially in front and on top of me. And so discovering these new environments opens up, I think, it does in me anyway, and I feel like it would with others, it opens up people to feelings that they maybe haven't felt in a while, or they don't know where they come from. And so this exploration of the music that Sharon and I are working on, it has things that are going to go out and become more over time. And that little thing about surround sound mixing and Atmos in this particular instance is something that you don't know if you don't do it. And so I just wanted to share that with you.
Yeah, we want to create an atmosphere where you really feel immersive. It's called, where you really like feel these energies, these higher level frequencies, and that's healing. That's healing. So here we go. Om Bhuvasvaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Yo Yona Prachodayat Om Bhuvasvaha Tatsaviturvarenyam Bhargo Devasya Dhimahi